morning, everyone. Thank you for joining us. My name is Edward Taylor, and I am the Director of Prevention Initiatives at the Addiction Prevention Coalition in Birmingham, Alabama. Our training today is titled Pain and Addiction, Harm Reduction, Relapse Prevention, and Psychoeducation. Our trainers today represent the forefront of substance use disorder research and treatment. Our first presentation will come from Dr. Leah Leish, Assistant Professor of Medicine, Primary Care and Substance Use Disorder Physician. We will have a 5-minute break after Dr. Leish. And then for our second presentation, Dr. Davis Bradford, Assistant Professor of Clinical Medicine and Substance Use Disorder Physician. After Dr. Bradford will break for 1 hour and 15 minutes. And we will finish with a third presentation on non-pharmacological pain management by Dr. Burrell Gooden, clinical health psychologist. So what I'm going to do now is go through our kind of housekeeping slideshow for all the CME technicalities and so forth. So let me share that real quick. Let's see. Share. Slideshow. All right. So there's the intro slideshow or the slide. There is some more information about CEUs. And also, I might go through this a little fast. We can certainly post it in the chat box. So here are the instructions for obtaining the credits. So you'll complete the eval after the presentation, the full presentation. There will be I'll put a link in the chat box at the end. When you're doing your eval, just indicate what type of CE credits you need. And then certificate will be emailed within 7 business days. And if you have any questions, there's the email we have set up for CE stuff. All right, let's see. There are no known conflicts of interest, and we have a document for this available upon request. So this is just a screenshot of what you'll see when you do that eval. That's what it's supposed to look like. Again, if you have any questions, there's that email address, and I'll go ahead and put that in the chat box soon. And then the UAB School of Medicine is one of our sponsors. And again, we're the APC. So let me stop sharing. All right. So just wanted to mention, if you saw on the flyer or the internet flyer, whatever you want to call it, the 4 objectives we have for the training today are explaining associations between pain and addiction, evaluate a patient's risk for substance use disorder, integrate harm reduction strategies into practice, and recognize signs and symptoms of a substance use disorder in patients. There will also be some objectives that may have changed a little bit, but as I was telling Dr. Leish earlier, I think all the information that will be shared today will be helpful for each of you going forward. And then one final housekeeping item, during our break, which will be between Dr. Leish and Dr. Bradford, I'm going to post, it's optional demographic survey questions. These are just for grant reporting purposes for us at the APC. There's no pressure to complete them, of course, and they will be anonymous. So before we get started with Dr. Leish, I just wanted to take a moment to add a quick, I guess you could say, a personal statement about this training. So this training is my first passion project since coming on as an employee here at the APC. And this is personal for me because I'm truly a grateful recovering heroin addict. Early on in my recovery, I noticed a blind spot, which was the inspiration for this. And the blind spot was kind of successfully managing pain for individuals in recovery, whether that was from the medical provider or more often with the person in recovery themselves. And it's seems to be a very complex medical situation. And I am fully on board with the patient with substance use disorder taking ownership of their recovery. But I'm also aware that one small misstep in care could lead to a relapse. So, for me and many others who have a substance use disorder or opioid use disorder, we tend to lose the power of choice as soon as we ingest substances. And we all surely can agree that addiction is a disease and not a moral failing or failure of the will. So it's my hope that the broad takeaway for those in attendance is as you could say, a newfound sense of confidence and competence for treating pain in those with substance use disorder or opioid use disorder. Because I've been on the receiving end of informed, collaborative, sensible medical care of pain in my own recovery. And I'll never forget that, doctor, because based on a few past experiences I'd had in similar situations, I was terrified. So, instead, my pain was successfully managed without narcotics, and I was back on the road to wellness. So I mention this not to emphasize a non-narcotic approach because y'all are the experts. I'm not a medical care provider. I just mentioned this to inspire each of you, hopefully, so you understand just how far a few small decisions can go when you're caring for a patient with substance use disorder. So lastly, I just wanted to express the deep gratitude that we have at the APC for our partners at UAB CAPI and the UAB School of Medicine. So as a nonprofit, we thrive when we have partners who are committed to our cause and the health of our community. And so to have world-class experts, and I'm not just saying that, join us in our fight to prevent addiction. Even eradicate stigma and heal those already struggling with addiction is seriously a dream come true. So I think we're right on time, and I will now turn the floor over to Dr. Leish.
Excellent start to the morning, Edward. Excellent start. And I will share my screen. As I'm sharing my screen, I will also share that this is a first for me. I have given, it says host disabled participant screen sharing. So I think we'll need to fix that up. I have given talks to the public before, and I have given talks to providers before. I have not given a talk where there's a mixed group of people. And so it was a little challenging to, excellent, I can share screen now, to know exactly what and how to present. And I will be honest in that I am a little bit tech not super savvy. So right now it's taking me just a minute to figure out how to share the best screen. Do you guys see my PowerPoint presentation now? Are you seeing the slide? Okay, I see a thumbs up from Virel. Awesome. Okay, great. And so I hope we cover the things you don't. I will say, because it is such a mixed group of people, I would love if anyone can just real quick, if a few people can kind of throw in the chat, provider, counselor, like a medical provider, like APP or MD, counselor, psychologist, interested layperson, person in recovery, all of those things, just so I can get a bit of a feel. Because there's a lot of people on this call, and I want to make sure I address things as best I can. That being said, my slides are somewhat short, and right now I presently have probably 4 different slide decks ready to load in case we need to pivot and discuss something else. So we'll go from there. We were asked to talk by Edward about addiction and pain. And so I will say, today we'll focus on the interplay of addiction and pain, specifically about the potential for acute pain issues to be a source of relapse or a barrier to sobriety for patients with known substance use. And I just want to clarify that this is not a comprehensive review of chronic pain management, nor a comprehensive review of substance use disorder management. This is more specific to what we do in the peri-acute pain period. However, I do have information about that, and if we have time about those other things, and if we have time, I'm happy to share more slides on chronic pain or more slides on substance use disorder treatment, depending upon what you guys might want or need to hear. I do always also start my talks with my confession. I call it healing. We all have our own confessions. I was not always a substance use provider. I did primary care and hospitalist medicine for 5 years before I became sort of niched in the chronic pain substance use disorder world. And so when I express things about how we judge patients, I say we, and I mean we. I've gotten better over time, but I don't want to feel any of the providers to feel singled out, because I've certainly had some fairly judgmental opinions on my own. I do ask for patients to be patient with us as we grow and learn, because we're all sort of works in progress. Objectives for my talk today will be to appreciate the complex association between pain and substance use disorders, and that by the end of this, providers will be able to practice evidence-based prescribing patterns in the perioperative or peri-injury period. Providers will be able to utilize evidence-based screening tools to evaluate a patient's risk for developing aberrant drug-related behaviors in the setting of long-term opioid therapy. And providers will be able to practice evidence-based communication strategies to facilitate open conversations with patients regarding the pain treatment strategies we talk about. So the outline is going to look a little bit funny in that we'll have 2 separate. Now, when you see my slide, do you also see the Zoom screen? No. Okay, you're just seeing my slide. Okay. We're going to have 2 separate little sections. One's going to be about addiction and screening for drug-related behaviors, and another section is about communication, because if I've learned anything over the past 5 to 6 years that I've been in this particular role, it's that communication is a huge part of taking care of patients with substance use disorders and with chronic pain. Honestly, we all do better when we become good communicators. Okay. All right. So let's start. I always start with a definition of addiction. I know a lot of you know it because you are providers. I see many of you, but I just like to make sure we're all on the same page. An addiction, as defined by the National Institutes on Drug Abuse, is a chronically treatable medical condition involving changes to circuits involved in reward, stress, and self-control. And we all know that for the brain, there's a difference between normal rewards and drug rewards. And this can be likened to the difference between someone whispering in your ear and someone shouting in your ear. And so normal things like food and sex and happy thoughts release some dopamine, and drugs release a lot. And that can result in changes to neurotransmission over time. One of the way those changes happen is through something called pruning. And pruning is where circuits that get used get reinforced, and circuits that don't get used get pruned. So the whole "if you don't use it, you lose it" applies also to brain circuitry. And so sometimes when we're talking about someone who's been using drugs for a long time and or started using drugs very early, instead of the well-formed multiple coping skill pathways that we would like, we have some aberrant pruning. And that's not to say that the person themselves is damaged, it's to say that the neurocircuitry isn't all working the way it should at the time. But just like this tree can regrow and be well formed, so can the patient's brain. We do know from neuroimaging studies that depending upon the drug abuse and how far down that pathway the patient has gone, it takes somewhere between 8 and 18 months for that neuroimaging to return to a normal baseline in regards to their dopamine and neurotransmitter distributions. And so it's, you know, every now and then we'll have someone call like from a jail or something, and they feel like because the patient has gone through withdrawal, that then they should be able to make decisions from, you know, day 10 onward, as a normal person might make a choice. And what we know is that actually the choice decision-making capacity is not stolen, but is definitely altered and hindered after this pruning. And that's why treatment becomes so important. I do also like to be clear about definitions. And so addiction is a broad term that applies to a number of things. It can be used in regards to talking about addiction to drugs or alcohol or gambling or even pornography. When we're speaking of drugs and alcohol specifically, we tend to call them substance use disorders. And then we get even more specific when we're diagnosing people, and we differentiate between each substance. So alcohol use disorder, cocaine use disorder, methamphetamine, benzodiazepine, opioid, marijuana, we kind of list them all out individually. And that's because there are specific treatments for each. There are some treatments that work well for multiple disorders, but there are some treatments such as methadone that are very specific to a substance use disorder. So like methadone and buprenorphine are used specifically for opioid use disorder. Right. And so throughout this talk, you may hear me say substance use disorder, or you may hear me refer specifically to opioid use disorder. And I'm actually, when I say substance use disorder, that means I'm talking about patients with any of these. And when I say opioid use disorder, I'm specifically talking about patients with OUD. All right. And so if we're going to talk about these and we're going to think about patients who might be at risk around the time of surgery or at the time of an injury, we need to know how to screen whether our patients have a substance use disorder. And so there is a screening question for substance misuse. I'm a person who likes to keep things exceedingly simple. And so there are several screeners, some longer than others. This is the NIDA single item screener because I like things very simple. And so this is one question that you would ask your patient. And the question is, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? For example, because of this experience or feeling it caused. And any answer other than 0 is considered a positive screen. And I see someone's putting in the chat different screeners like the SASSY. There are definitely multiple screeners out there. I start with this one because it's just one question. And then if the answer is anything other than 0, you do further questioning. And I do want to emphasize that this is a screener for substance misuse. Substance misuse is different than substance use disorder. And so this is, for instance, substance misuse might be someone who fell and injured their knee, and they couldn't get into their doctor until a Wednesday, and they were very, very hurting. And so they used their family members' hydrocodone, and they used it twice, and then they saw their doctor and they got a knee brace and some prescription anti-inflammatories, and then they never used hydrocodone again. Substance use disorder is more like, you know, you use a family member's hydrocodone and then you use it again and again and again. And then before you know it, you're using more than you mean, and it kind of takes over. And obviously this is a bit of a dramatization because it doesn't happen in just like 2 weeks, but that's the concept, that there's something different between substance misuse and substance use disorder. And the way we differentiate that is with the DSM-5. And so the Diagnostic Statistical Manual, 5th edition, says substance use disorder can be categorized as mild, moderate, or severe based on the number of these criteria that the patient meets. There are 11 criteria, and you're asking about the preceding 12 months. And if a person meets 2 or more of these criteria, they have a substance use disorder. 2 to 3 is mild, 4 to 5 is moderate, and 6 or more is severe. And we do this by each substance. And so you wouldn't necessarily just say, oh, this is a patient with substance use disorder. You would ask specifically about these criteria in regards to opioids, specifically about these criteria in regards to alcohol, et cetera, and then you would diagnose mild, moderate, or severe of each of those substances. Okay. So A lot of time, so the basis of this talk is what to do if your patient with a substance use disorder needs a surgery or has an injury. And I will say in general, you can actually disregard the whole substance use disorder line at first and say, just what if my patient needs surgery or has an injury? And if your patient needs surgery or has an injury, you want to talk with them about pre and post-operative expectations. You're going to outline the usual recovery process, and you're going to discuss plans for pain management during hospitalization and beyond, and plan for follow-up. Really, the only things that change if your patient has a substance use disorder history is that you're going to plan for pretty close follow-up. So maybe you would follow a patient normally in 2 to 3 weeks after a painful hip surgery because you want to give them time to have their physical therapy and really start the healing process. For a patient with a substance use disorder, you should probably follow them more like 2 to 3 days or at most 1 week after that surgery. And the reason being is that uncontrolled pain can be a nidus for relapse for patients. And so if their pain is uncontrolled, you want to know that sooner rather than later. The other difference is if specifically a patient has opioid use disorder, you want to plan to use higher doses of opioids because they're probably going to have tolerance. And you want to be knowledgeable and or seek help in managing their medication for opioid use disorder. If they're not on it at the time of surgery, you want to talk to the patient about if they might need it after surgery. I'm not saying that they necessarily would, but you would want to be prepared for that. And so again, you either have to know how to do it yourself or know who you can refer them to. And it's important for anyone caring for patients with pain, whether this is acute pain or chronic, to know how to prescribe opioids and manage those opioids, because opioid misuse is predominantly linked to physical pain. And so when we think of substance use in general, we sometimes think of patients pursuing those to get high, and certainly patients sometimes do use opioids to get high. But when you ask specifically about opioid misuse, and again, oftentimes opioid use disorder begins first with that misuse. Opioid misuse is usually motivated by relief of physical pain, more so than feeling good or getting high. And so managing that pain becomes critical to prevent relapse, or in patients who don't yet have an opioid use disorder, to prevent development of opioid use disorder, because it's not unheard of for someone with, say, a history of alcohol use disorder in long-term remission who then has an injury and is placed on opioids, and then the opioids continue, and they now develop an opioid use disorder. So pain management becomes critical in that setting. All right. That being said, that doesn't mean that we would always use opioids for that pain management. Specifically, we tend to use opioids around major injuries and operations, and we do have evidence-based durations for opioid prescriptions upon discharge from different operations. I'm not going to go through these line by line. I just wanted you guys to see the vague outline of it. And I think this is very important for patients and providers. It's common that we'll have discussions in the hospital with patients who maybe have an injury. They end up having their femur nailed and pinned. And you explain to them that you hope that by 2 weeks, they're going to be off of opioids or about to be off of opioids. And sometimes patients will be very defensive and they think that it's because of their history of opioid use disorder or because of their history of some use disorder, when in reality that these are actually the expectations for all patients. This is not a substance use disorder specific population. This is guidelines for everybody who has surgery. And there are lots of reasons why we try and get patients off opioids faster. And one of the major reasons is we now know that the longer you're on opioids after a procedure, the more likely the pain is to become chronic. And that has to do with some regulation of the mu opioid receptor and its downstream signaling that tends to change when you're on opioids for a long time. And so then the question becomes, what if my patient is still having pain after this expected duration of therapy, right? And so although our patients with OUD may need higher doses during the perioperative period, they shouldn't need opioids any longer than a patient without a history of OUD. Same thing for patients with substance use disorder. Patient with alcohol use disorder wouldn't necessarily need higher doses because they're not going to have opioid tolerance. They have alcohol tolerance, but they also wouldn't need opioids any longer than your average patient. And so anytime we're running up against these sort of taper by recommendations, we really, really need to be asking what's going on. And so the question becomes, what if the patient still hurts toward the end of that period? So they've had their injury and now they're on week 4, and you feel like they really, really should be tapering, but they're using more opioids than you would expect. I mean, and you may identify this even at week 1, right? So somewhere between 7 and 10 days, even after a major injury, they should be using less opioids than they were on the first postoperative day and the second postoperative day. And if they're not, we need to be asking ourselves what's going on. So we need to thoroughly investigate the possible etiologies of that. I actually did try to find statistics on what percentage of patients relapse around the time of surgery, and I was not able to find a really good article about that. I did find a case series of patients undergoing back surgery, and it was about 20% of patients who had back surgery who had a relapse during that time. Several of the patients who relapsed actually had, they relapsed within a week of surgery, and it was due to uncontrolled pain. And several of those patients actually were subsequently found to have an infection of the surgical site. And so the uncontrolled pain was related to a intervenable etiology that wouldn't have involved opioids, right? Like we wouldn't have treated surgical site infection with opioids, we would have treated it with antibiotics. And so investigating those possible etiologies is critically important. We also want to encourage the patient to engage in a robust multimodal pain care. So Dr. Gooden will talk later about non-pharmacologic pain care, which I am a huge fan of, and really see more improvements with that than most medications I prescribe. I actually sometimes cringe to call myself a pain management provider because I feel like my role is pretty small compared to everyone else who helps support my patients. You're going to also optimize non-opioid pharmacologic interventions. So we do have good evidence that some other medicines like SNRIs, some of the gabapentinoids like pregabalin and gabapentin can be helpful. And then you would consider changing their opioid to a medication for opioid use disorder that might also result in some pain relief. So for those of you who aren't as familiar with medications for opioid use disorder, your choice for that would be buprenorphine or methadone. So there are 3 FDA-approved medications for opioid use disorder: buprenorphine, methadone, and Vivitrol, or naltrexone. But naltrexone is a mu opioid receptor blocker, and so it doesn't provide analgesia at the doses used for MOUD. If you were to put your patient with a history of opioid use disorder on methadone for pain, you would still want them to get that methadone through a federally registered opioid treatment program, because when pain and OUD overlap, the risks of OUD are so high that you need it managed first and foremost, and you can't ignore it. Buprenorphine is the favored treatment for a lot of people, just because it's not prone to as many adverse effects as methadone, and here in Alabama because access is better. But when it comes to life-saving effects of either medicine, they're equal. If you were in a desperate situation and for some reason the patient was not willing to be on MOUD and did not have a history of opioid use disorder, you might consider putting them on long-term opioid therapy. You'll notice that I grayed out this arrow, and that's because this really, really, really should be considered not an escalation of care, but a last resort. My analogy I like to make for this for providers is that long-term opioid therapy is not the insulin of pain care. It's not like if your sugar gets high enough, we can put you on insulin. If we put you on enough insulin, it'll control your sugar. It's not if your pain gets bad enough and we put you on opioids, we put you on high enough doses of opioids, it'll control your pain. That's actually not true. We know that's not true. In fact, what we know is that when it comes to long-term chronic pain, long-term opioid therapy is as likely, if not more likely, to harm our patients. And so we should actually think of this switch to long-term opioid therapy as more like salvage chemo. Like this patient is at risk of death through suicide or some other means if I don't do something. And if I do something, just like if I were giving someone salvage chemo, I would be monitoring that patient exceedingly closely to make sure I wasn't harming them rather than helping them. And how we help talk about that risk with patients and how we help decide what those risks and those harms for considering this long-term opioid therapy are is with other validated tools for doing that. You'll notice I've grayed out the slides for this one section. That's for two reasons. One, because now we're talking a little bit about chronic pain as opposed to the acute pain episode, but I felt like that was important because that's where I feel like things get extra muddy is both providers and patients get concerned about when do I know when I need to stop this and what happens if I'm still in pain. And so this is focusing on patients who might remain, those few patients who might remain on long-term opioid therapy and how you would decide who that should be. And so this is one of the validated instruments we use when we're considering placing a patient on long-term opioid therapy. It's called the opioid risk tool. It's 9 to 10 items. It started as 10 and then they took out one item and found that it was just as valid. These come from personal and family history items that you're probably going to know about the patient without specifically having to go back and do a secondary survey or secondary questioning of them. The physician normally interviews the patient and then scores this result. It is available on MD Calc if anyone has the MD Calc app. That's one of the things I love about it. And it helps predict the probability of developing aberrant drug-related behaviors within the first year if a patient is placed on long-term opioid therapy. And risks are stratified as low, medium, or high. This tool does have 85% sensitivity and 85% specificity, which if you're not familiar with many screening tools, this is actually exceedingly high. So it's a very good for specificity. It's a very specific tool, meaning if it's positive, it's telling the truth. It has some good prediction about who's going to not do well on these medicines. And so in this, I'll tell you that low risk is a score of 1 to 3. You can see that the scoring is different for females as it is for males. The categories are the same. The thing that was eliminated in the subsequent edition of this, which is the 9-point history, is the history of pre-adolescent sexual abuse. Whether we ask about that or not, the scoring is still valid. And a score of 1 to 3 is low risk. A score of 4 to 7 is moderate risk. And so a low risk patient will have about a 5 to 6% chance of having aberrant drug-related behaviors in that first year. A moderate risk patient will have about a 28% risk of having aberrant drug-related behaviors in the first year. So that's already a quarter of your patients who are moderate risk. A high risk patient will have a 91% risk of having aberrant drug-related behaviors in the first year. And so I do not start patients who are high risk on long-term opioid therapy. I offer them buprenorphine or methadone through an OTP because high risk, 91% chance of my patient having struggles, this is just too high. I mean, that's really gambling against the odds. And I also try and avoid moderate risk if at all possible. And so that's for patients that you're thinking of putting on an opioid. If your patient does end up on a long-term opioid, one of the evidence-based screening tools you can use is the current opioid misuse measure, or the COM. This is a 17-item questionnaire with a Likert scale ranging from never to very often. The patient actually completes it on their own, and then the physician scores it. And it's designed to predict if a patient is misusing their opioids. Again, this is not diagnosing an opioid use disorder. It is looking for opioid misuse. A score of 9 or greater is considered positive. It has 77% sensitivity and 66% specificity. And again, emphasizing this is looking for misuse, not use disorder. And so what does that survey look like? So these are some of the items on that survey. Again, there's 24 items, so it goes way beyond this. If you are a patient or someone who's interested in just looking at your own score, you can find it easily on the internet. If you just Google image current opioid misuse measure or COM opioids, you'll find this out there. And it asks questions like, in the past 30 days, how often have you had trouble thinking clearly or had memory problems? In the past 30 days, how often do people complain that you're not completing necessary tasks? How often have you had to go to someone other than your prescribing physician to get sufficient pain relief, et cetera, et cetera. And then the patient answers never, seldom, sometimes, often, or very often. I will say for the providers out there, this is a screener. It does take patient participation. It is not a lie detector test. Have I had patients who have checked that they have, never gone to a provider in the past 30 days, and then we do their urine drug screen and they have non-prescribed opioids in their urine? Yes, I have. But that's just a talking point for you and your patient. And I offer this up as a tool because it's evidence-based and validated. And also because I find that most patients, if you have sort of an open, working, collaborative type relationship, most patients will be fairly honest on this because they want to know if they're at risk or starting to have problems. Again, this is screening for misuse, not use disorder. So we would go back and we would say, if someone is having misuse, are they developing substance use disorder? I will be honest, sometimes with pain, this gets very, very sticky because something like a larger quantity over a longer period of time, the patient would say, I have, but that's because I'm in pain. Like unsuccessful attempts to cut back, yeah, because it still hurts. And so sometimes it gets what I like to call clear as mud. And you just really get to a point where you're like, I don't know, is this use disorder? Is this all uncontrolled pain? Is my patient about to get his dinner with this fishing net, or is that the snake that's going to bite him and kill him? I don't know. This is really confusing for me. And so what I do in that situation, if I'm not fully certain it's substance use disorder, is I start asking myself and asking the patients, do the benefits of this medicine really, really, really outweigh the risks? And for those of you who are treating patients on long-term opioid therapy or who are patients on long-term opioid therapy, it's really important that you know all of the risks of that therapy. And so most of us are familiar with the common acute adverse effects of opioids, including constipation, sedation, and respiratory suppression. Many of us, even though we prescribe these medicines, aren't as familiar with the long-term effects of those opioids, which include hyperalgesia and allodynia. So hyperalgesia being things that would normally hurt, now hurt more. Allodynia being things that wouldn't normally hurt. And so some patients will develop even like skin sensitivity where you touch them and they're just jumping off the table. And this just creates a worsening pain conundrum over time, and that can be driven by the opioid. Long-term opioids are also associated with osteopenia. I have several patients in my chronic pain practice who've been on opioids for greater than a decade who now have fragility fractures. So they have vertebral compression fractures. So they started with disc disease and now they have broken vertebra from their opioids. And so we need to be monitoring for that if we have patients on that. They can also cause immunosuppression and they can cause adrenal insufficiency. That being said, those things are true of full agonist opioids. So that's the things that fully open the mu receptor. So that's every opioid other than buprenorphine. And so while buprenorphine does cause the common acute effects, it tends not to cause the long-term effects like the full agonists do. That's why buprenorphine is the preferred agent if someone is going to continue on opioid therapy, particularly beyond that immediate post-op period. And buprenorphine is often used in the immediate post-op period for analgesia. It is a very effective analgesic when used appropriately. All right. So that's the end of part one. And here's my summary on managing patients in the peri-op period. That being said, Dr. Bradford's going to speak more with you and do a bunch of case series after my talk about in-hospital management of patients with acute injuries and or operations who are either in recovery or with active use. And so I didn't want to overlap too much with his content. And that's why I focused a little bit more on what to do as we move into that. What if the pain still lingers beyond the acute period? So in summary, uncontrolled pain and opioid exposure are both risk factors for addiction and recurrence of use. Patients with a history of opioid use disorder may require higher doses of opioids due to tolerance, but they should not require the opioids longer than usual duration. All patients being considered for long-term opioid therapy should be screened routinely with the opioid risk tool. That's patients with and without a substance use disorder. And all patients on long-term opioid therapy should be screened regularly for signs of misuse using the current opioid misuse measure. Patients with misuse should be evaluated for OUD with the DSM-5. And if the diagnosis is unclear, you can ask yourself, do the benefits of this drug outweigh the risks? All right, so now we'll go into part 2 about communication. And you are certainly welcome to participate in this if you would like. So in communication, I did want to start with the reminder of my confession that I was not always a substance use disorder provider. I was in general primary care beforehand. And when I first started doing, I honestly first started with chronic pain care out of necessity more than anything else. I was in resident clinic and a lot of the residents weren't quite sure what to do with the patients. Sorry, let me silence that so it doesn't make us all nuts. That's what happens when you have 2 phones. And the more residents asked me questions, the more I realized I wasn't fully prepared to manage this. And that wasn't unique to me. In fact, pain education, pain and addiction are fairly new to the medical education curriculum. So you can see that back in 1997 through 98, less than 3% of medical schools offered any course on pain management. Even by 2000, 2001, only 3% offered courses on pain management. And even as far as 2014, less than half of schools included any course on opioids and addiction medicine. Now you can see that the verbiage changed. These are all surveys of the certifying body of medical schools. And the certifying body changed it from a requirement on pain management to a requirement on opioids and addiction medicine. And so still sometimes we don't have a lot of education about pain management. Unfortunately, what that results in is that residents, when they graduate, don't feel prepared to prescribe opioids. And so this was a survey, a 2010 survey in which 16 residency programs that did not have a current residency curriculum on chronic non-malignant pain. So that would be one of these greater than 50% programs that didn't have content on pain management. Their residents, this is their first year residents for doctors in their first year out of med school, second year out of med school, third year out of med school, and about to become, a free independent practicing provider, expressed that they did not feel very confident or even confident in prescribing opioids by the end of their training. In fact, the majority of residents still said that they were not confident in that. Interestingly, in this same survey, you can see that without training, residents learned negative opinions of both the management of chronic pain and the patients with that pain. And although this survey was about chronic pain, I will tell you that this also applies to patients with a history of substance use disorder and acute pain. And Dr. Gooden's like, yep. And probably every patient in recovery who's interacted with the healthcare profession is like, yep. And those negative opinions grew over time. So again, this is their first year of training, second year of training, third year of training. And when asked to describe patients, characteristics of patients with chronic pain, you can just see that over half of them describe them with psychologic terms like anxious or unhappy or having mood problems. And then almost a third or over a third, almost 50% of people right about to become independent practicing physicians actually used even derogatory terms like demanding, irritable, sneaky, unmotivated, and less than 10% had anything positive to say about these patients. In addition, when asked how they felt about working with patients with chronic pain, providers, most of them had somewhat neutral things like, well, it's challenging or it's part of my job. But again, over a third had negative opinions. And so this is, not a specific patient. This is these patients in general, annoying, aggravating, depressing. And again, only around that 10% had positive things to say about managing chronic pain. And so in the absence of education, what happens is learners kind of learn an implicit bias about patients that they then carry forward into their future encounters with patients. And that's why I became so passionate about teaching people how to communicate with each other around pain. The good news for those of you out there is that this is improving. This is a 2018 AAMC survey asking medical schools what percentage of them offer. They now have 4 domains addressing both pain and substance use disorder, and also opioid prescribing, and everything's getting better. There's much more education around that now. And so I have tips for communication, and I've separated them into 3 categories. The first category we're going to talk about is for patients and tips for communicating with their provider. I'm sorry, I wrote physician because it was a default for me. I should say provider about pain. So this is whoever's controlling their pain medicine or pain medication, pain management program. And if there aren't a ton of patients on here, which it seems like we're mostly providers on here in some way, shape, or form, then I would ask that you as providers, particularly anyone outpatient, prep your patient with these thoughts before they go into any inpatient setting or before they have meetings with surgeons, et cetera, et cetera, et cetera, so that they can have a better expectation of the interactions around pain. Because I think it's important for patients to understand that many of their providers weren't trained on pain. And when we're not trained, we can sometimes be defensive and that results in some negative interactions. And so learning for enabling patients to nip those interactions, or not nip, to engage in those interactions in a proactive manner empowers them to have better interactions. So when they're interacting with their providers around pain control, I find it's helpful for patients to remember that providers have been manipulated before. Rarely will you find a patient with a substance use disorder who will tell you that lying or manipulation were never something that they ever did, right? Active substance use is laden with lying and manipulation because it's part of the disease. It just is. And knowing that providers, by and far, particularly in the inpatient setting, deal a lot with patients with active substance use and a lot of manipulation, can help patients who are in recovery be a little more patient with their provider. And so I'm actually, you can see right now, I'm in my clinic. This is a primary care substance use disorder clinic. I am passionate about having residents come and rotate here. I call it their healing experience. That's because usually when they're interacting with patients with substance use disorders, they're doing it in the inpatient acute setting where patients are at their worst of their worst of their worst. And then that becomes their opinion of patients with substance use disorders. Because even if they are in the hospital caring for a patient with a history of substance use disorder in remission, they often don't know that because patients will sometimes not tell us that. So we only know when patients are like at their most terrible moment. And so then we develop this really negative opinion. And so I like residents to come here and see the other side of that. And so when you're a patient, you have to remember that most of what inpatient providers see is people at the worst of the worst of their worst. And that's going to make them a little prickly. And so then unfortunately, it almost becomes the job of the patient to deflate some of that angst that the provider walks into the relationship with. And so I find using some very general questions can help waylay some of that tension that the provider has. And so one thing would be like, how will we know if this regimen is working or not working? And what is the best, like, to just tell them, like, I'm afraid that anytime I say I'm in pain, you're going to think that I just want a drug. Is there a way that I can express that I'm in pain without you thinking that I just want opioids? And that, if nothing else, helps the provider recognize that 2 things can be happening. You could be asking for opioids to be manipulative, or you could be in pain. And it's good. It's a good reminder for the provider. It's also helpful if you're someone who's very concerned about your pain, but not particularly seeking extra relief from it, but just concerned, to tell them, I'm not asking for opioids. I'm concerned that there's something wrong. And I know Dr. Gooden will talk a lot about the psychologic base of pain and pain relief. I'll just give the example. Recently, I had an eye procedure. As part of that procedure, they put a protective contact in, and he told me, like, oh, it's going to feel like soap is in your eyes. It's going to be a little painful. And I would say it felt like bleach in my eyes. Like, it was horribly painful. And then that made me paranoid because it exceeded my expectation of what I thought I was going to be in, that the contact had shredded and it was like tearing up my cornea or something. And then that added anxiety to my pain, which made the pain worse and just made my psychologic state worse. And I was able to go to the doctor and tell him, like, look, I just need to tell you, is the contact still there? Did it fall out? Did it shred? Is something wrong? And just having him say, like, everything's okay. I'm sorry, it hurts more than you expect, but you're healing normally, helped my mental state and my pain, right? And so we can all kind of relate to that scenario where we need to know. And because we've been manipulated, because providers have been manipulated often enough, if you just go and you say, like, it hurts, and you don't tell them it hurts and I'm concerned that something's wrong, they're going to immediately kind of flip into this conversation about opioids with you as like their default communication. One of our peers who's in long-term recovery said it took her 3 ER visits to get an x-ray for her arm when she broke it, because she was in active addiction at the time and had track marks, and they were just like, no, you don't need opioids. And she's like, no, I don't care whether you think I need opioids. I care if my arm's broken. And so sometimes you have to really tell them exactly that you're concerned about that. Also, remember that your physicians are there to help, and we can sometimes become very uncomfortable when we can't make people better. And so if your pain is greater than what we expect, it may not be only disconcerting for you, it may be disconcerting for your provider. And so just giving them a little reassurance, because providers are people too, and let them know, like, it's not their fault that you're still in pain. Thank them for trying to help, and avoid threatening words or behaviors, like avoid threatening to sue them, avoid telling them that you're going to leave, avoid telling them, if you don't give me something, I'm going to find something, because all of that just pushes the provider's brain straight back into this person's manipulating me, and doesn't become helpful. And so just everything you can do to kind of build a rapport and reassure the provider. I know it's sad to say, like, you as a person in pain has to become responsible for your provider's reassurance, but it really does. Yes, that term drug-seeking behavior is widely used. And whether it's true or not, in some cases, are there patients who have active opioid use disorder who are stating they have pain greater than they do to seek opioids? Sure. And actually, one of our peers in long-term recovery is really great about saying, in that moment, we believe our own lies. Like, she's like, yes, in that moment, I absolutely thought that my knee hurt so much that provider had to give me more opioids. And it wasn't until in long-term recovery off opioids that the knee pain was better, that she was able to, sort of see the drug-seeking component of that. Other tips for communicating with physicians about your pain is to remember that your physician may not have had a lot of training on the opioids and pain. And so it's okay to ask. If you feel like, hey, I've asked in the nicest ways possible and I'm still in horrible pain, you can ask, is there an inpatient pain or addiction team? Or if I weren't a person with substance use disorder and I were still having all this uncontrolled pain, what would be the next steps, or who would you ask for help then? Is there anyone else we can ask? And then remember the value of teamwork. So like Edward was mentioning, you have to be empowered to manage your own pain. And so ask your provider, how can we work together on this? And what else could I be doing that might be helpful? And if necessary, just call out the providers, what you're sensing from the provider. Like, you seem defensive, or you seem angry. Is there something specific I've said that is making you angry? Is there something specific I've said that is causing this?
Hey,
Edward,
Dr. Fleisch,
yeah.
I'm sorry, I didn't mean to interrupt. I think you mentioned that people could interact with you on this.
Yes, absolutely.
There's somebody that has their hand raised.
Sure. I'm sorry, I couldn't see it when talking.
Yeah, that's okay. I'm not sure if I'm going to go ahead and allow them to talk, though. Yeah. Oh, just kidding. They took their hand down. So I will. I'll give the floor back to you.
Yes, well, so Burrell actually shared. I couldn't see who was sharing. I try to think about it more that people are relief seeking and just trying their best to cope. That's a really great phrase, Burrell. It's a really great phrase. And perhaps the coping with opioids has become a problem, and it's our job as providers to try and understand and help that coping issue. And someone else was talking about being a mental health professional and having negative experiences with physicians early in treatment for pain, for medical disease in the late 80s and 90s, even with no history of substance use disorder. And I can tell you, it's funny, I am a substance use provider. I have a visible tattoo. And I've had providers sort of say to me stuff like, well, I don't know what you've been through and whatever. And I honestly don't tell them whether I have a history of substance use disorder or not in those moments, because I feel like kind of letting them think that I do maybe is part of their healing, because they can see some, you know, they can believe whatever. But yeah, it's wide and it's out there. Countertransference is real. And so for tips for communicating that's all I have on tips for communicating with your physician about your pain, tips for communicating with patients about their pain. I'm huge on do not ever wrestle with your patient. We should not be trying to drop kick them. We should not be trying to convince them that we are right and they are wrong. It will never work. They are the driver of their own car, and we are but merely passengers. And so I'm huge on collaborating with my patients. I do have puzzle pieces to offer. I did go through a lot of medical education to help give them skills, but in reality, they're in control of their own life. And so I'm all about collaboration. That being said, I am a huge fan of motivational interviewing for patients with chronic pain and acute pain and substance use disorders. Using motivational interviewing, this is a lovely quote, in the proper spirit requires almost constant internal monitoring by the therapist or provider. Certain emotions, such as an urge to persuade, confront, or warn the client, is assigned to stop and choose another direction for our therapeutic efforts. And so anytime I find myself like wanting to interject over the patient and say, but, or to just counteract everything they say, I will just pause. And sometimes I'll just be quiet for a minute because I have to collect my own thoughts, because all of those buts and counter arguments are exactly that. They're arguments and they're not collaboration. And so learning to reframe the way we think is very important. I also want to be explicit in case anyone is confused. Motivational interviewing is not a mind game. It's not mind tricks. It's not manipulation of the patient. I like to think of it more like manners. It's the polite and kind way to speak with patients about their pain. And we're going to talk about that a little bit. Someone asked, what is the end of the quote? Mentioned people are just relief seeking. I think that you're maybe referring to Dr. Gooden made a comment to think of maybe change the wording from people who are pain seeking to people who are medication seeking to people who are relief seeking, because you can agree on that. That actually ties right in line with my rationale on motivational interviewing. And this is not a talk on motivational interviewing. I imagine since a lot of you are counselors, you probably know more about MI than I do. Although what I have learned is that you can sometimes learn the content and the procedures of MI without knowing the spirit of MI. And so I just wanted to take a moment to talk about the spirit of MI. And that is that willful, positive view of your patient with a collaborative spirit of how to help them. And so another quote I like about MI is, if you wish to know the mind of a man, listen to his words. And sometimes we hear what the patient tells us, but we don't hear, or we hear what the patient's saying without hearing what they're trying to tell us. And so I'm going to step away from substance use disorder for just a minute and talk about diabetes, because sometimes that can be a little less stigmatized. And I'm going to use this example. So sometimes when I ask a patient about their diabetes and they say, look, I don't check my sugars. You know, I hate those shots. I just can't convince myself to take them every day. And there's no way I'm poking my finger 3 times a day. I'm probably only taking them about 2 or 3 times a week. And if I could stop eating all the sweets, I know I might not have to take the shots, but I just can't seem to stop that either. But don't worry, doc. I know my sugar hasn't been that high because I feel sick when it's there, right? And we as providers sometimes hear like all this stuff in red and we're like, oh my God, they're not doing what I told them to do. They're not taking care of their diabetes. They're not doing this, they're not doing that. And we get into like, they call it writing mode. Like we just want to right all these wrongs. We want to fix it. We get into fixing mode and we start giving the patient all this advice. What motivational interviewing with the spirit would say is to listen for what they tell you about what they're doing right, to listen to the positive things about them. And so what you need to hear when this patient says all this is that they are taking their shots. So they've already told you that they hate them and they can't stand doing it, yet they're doing it. What drives them to do something they hate? And then that's what you want to talk about. And that's where you want to meet your patient where they are and start from there. Because they know that it makes them sick because they tell you that toward the end. And so I don't need to spend time telling them they're going to lose their feet and their eyes and all that because they know that. I need to spend time figuring out what makes them do something they hate at least twice a week, because if they're doing it at least that much, maybe I can convince them to do it more. So if you take that and kind of put that on to the topic at hand, which is opioids and pain, then you might have a patient who's like, they come back to their 7-day follow-up and they've used all their pain pills and like they used them up in 2 days and then they had to get they're like, look, I tried to get pills, but pills are too expensive. So I bought heroin. Like I had so much pain. You don't understand. I had so much pain. And like, all we hear is like, blah, blah, blah. Oh my God, they used all their pills and they used heroin. Like this is relapse. I'm going to tell you that probably a patient with substance use disorder knows more about relapse than I do. And so it's important for me to also hear the things that are positive, right? They don't want to relapse, right? They recognize that relapse would be bad and they're having a ton of pain. And so they're having pain and they're concerned about relapse. And so I don't need to tell them how concerned I am that they've relapsed because they're concerned about it too. They don't feel they have it right now. But I need to address this pain so that we can prevent relapse. Does that make sense? And you have to kind of meet your patient there and move forward from there. And when you're doing that, I suggest going back to that slide where I talked about what do you do if your patient is having pain that's not explained? So pain beyond the normal duration or pain in greater amounts. So first, investigate things that might be wrong. And start kind of going from there. So when we're doing that, it's important that we think about the patient's perspective as well. So just as I had tips for patients communicating with providers, this is tips for providers communicating with patients. And so remember that pain is a symptom of something going wrong. And so you want to be really, 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 really sure that you are fully evaluating potential etiologies of that pain. In addition, remember that patients in acute pain may not be the best historians. So sometimes, they say we may ask them a question or two, and it doesn't sound like something to us. I'm going to say, if you don't have an explanation, dig further. I had a patient like, hey, any fevers, chills, night sweats? And the patient was like, no. And the wife was sitting there next to him and was like, are you kidding me? Like your pillow was soaked this morning. But the patient was just like, well, that's because I hurt. I wasn't sweating. And she was like, but you were sweating. And so sometimes that pain makes us not able to think the best that we can. And so it becomes sort of our job to do our best to get collaborative information and get seek information from spouses or from people around the person if we can. Also remember that pain evokes many negative feelings like anxiety or loss of control. And so you want to do your best to reassure the patients of anything that has been or will be evaluated. So again, kind of like the contact example, sometimes just knowing, like, I know you're really concerned that the nail has moved, but we did an x-ray and the nail is still in place. Having pain after this procedure is actually really normal. We've checked labs. It doesn't appear to be infected. If you continue to have this pain, we'll consider doing an MRI, which is even more sensitive to looking for infection. But I promise we're not going to leave you stranded, because that thought of being out of control is very anxiety provoking, and then the anxiety worsens the pain because anxiety causes muscle tension and all of those things. And then offer choices whenever possible. So for instance, when we're in the hospital or even outpatient and we have to taper patients' medication, they may be on, so say they're on, a patient with opioid use disorder might be on something like oxycodone 30 milligrams every 4 hours after a major surgery. Like it's a super high dose. And we're like, oh my gosh, I can't write this prescription going home. Let me see if I can get them down a little bit. And we may walk in and we'd be like, okay, we're going to change it from every 4 hours to every 6 hours. And they're like, oh my God, I've been watching the clock and like dying at hour 3. What do you mean you're going to change me to every 6? So instead, what I do is I say, look, it's really important that we cut back a little bit somehow. One of the ways we can do that is to change to every 6 hours. Another way we could do that would be to change some of your doses from 30 milligrams to 20 milligrams. Another way we could do that is to rotate to a different opioid, like morphine. Of those options, what sounds best to you? Now, that doesn't mean that I'm going to necessarily give the patient the option of like, well, we could just stay where we are or we can cut back, right? So we know as providers, staying at that high dose for a long period of time is going to cause the increased pain on the back end. And so we don't want them to do that, but there are multiple ways that we can proceed in a positive direction, and giving the patient the choice in that the choice of those ways empowers them to be more a part of the team. The other thing to remember when you're communicating with your patient is that even kind, honest, wonderful people can be grumpy and mean when they have enough pain. And so I always try and ask myself, if someone seems to be acting belligerent or aggressive, like what would make a reasonable, rational person act this way? Like how much pain or how much stress might be contributing to this? And I will sometimes even ask patients, like, and even call it out sometimes, like, you seem very, very hostile right now. I'm wondering what percentage of that hostility is coming from being in pain versus coming from something that I'm doing versus coming from not being able to sleep because you're in the hospital, and just kind of ask the patient to kind of parse that out, because that helps you address that hostility in a more productive manner than just saying like, well, you're being hostile and unreasonable and I can't deal with you like that. Also remember to not judge the patient too quickly based on their behavior while in pain. Again, even our most beloved loved ones can be buttheads when they're in pain, because it's not fun. Even ourselves can be mean when we're in pain. And then to acknowledge our own biases. Again, going back to that study that showed that people have a negative opinion, to acknowledge that you probably had some reservations about this patient before you ever even met them. And if you can't get over those biases, to get another provider. To ask a colleague to take over the patient's care, or to consult a pain specialist or something. If it just becomes something where if you feel anxious or angry before you even open the door, it's probably time for that patient to have someone else caring for them. All right. I'm also a huge proponent of the fact that your documentation advocates for or against your patient. We know this as a fact. There is a science behind language. This is just one study kind of demonstrating that. They interviewed 728 mental health care providers. They were attending this conference on addiction and mental health care, and they gave them a survey. And the surveys were kind of randomized, really just like what survey got picked up. And it was the same clinical vignette, but in one vignette, the patient was listed as a substance abuser who was in recovery, and the other person was listed as a substance use, or not in recovery, sorry, a substance abuser, and the other person was listed as a substance use disorder. And they were having some, presenting for some clinical care and having some problems. And they were asked whether the patient should receive more therapeutic or punitive actions, and whether the patient posed a social threat or could regulate their own behavior. And those who were randomized to the substance abuser vignette, so again, the vignette is completely the same, except for the term substance abuser versus substance use disorder, patient with substance use disorder. And those who got the ones that said substance abuser were statistically more likely to agree with punitive actions rather than therapeutic actions. And so we know, I'm sorry, my light is linked to the bathroom. And so every time someone uses the bathroom, turns the light off, my light turns off too. But so we know that even just that one term can make our mind more likely to punish a patient than help them. So with that in mind, I will take an example from one of my patient's charts. The patient did give me permission to share this information. It doesn't have any identifying information in it, but I'm just going to show you an example of documentation. So it says the RN was paged, stating the patient was complaining of severe pain and threatening to leave AMA, requesting to see a provider. Immediately after that page came through, I received a phone call from our office manager who said the patient's spouse searched online for a phone number and called into her administrative office demanding for someone to find Dr. X to come evaluate patient immediately. When I went to the bedside to evaluate the patient, the spouse was not present. Patient is complaining of severe pain on left forearm at IV infiltration site. Arm is red and swollen. Patient claimed he could not move his arm since the IV infiltrated. I palpated the site in question and the patient immediately withdrew his arm to pain using both gross and fine motor movement. He can move all his fingers freely and I have no concern for compartment syndrome. I do have concerns that the patient is exhibiting malingering or drug-seeking behavior. I explained to the patient we do not typically give narcotics for infiltrated IVs, but rather use conservative management until the fluid is reabsorbed and the swelling goes down. I've placed orders for his arm to be elevated above the level of the heart and to alternate hot and cold packs PRN. I've also ordered an ultrasound to rule out abscess or DVT at the site. The plan was discussed with the bedside nurse. Whew, that was a mouthful, wasn't it? Like that was a lot. That was like a monologue. If you're the provider who's picking up the patient the next day, do you want to go see this patient? Are you anticipating a positive interaction with this patient? Negative, right? No, you're like, oh, I have to see this patient. You've never met him. Like you've never met this person and you're already like, oh. And we know from science that if the patient's a history of substance use disorder, you started that way anyway. And now it's like even worse. Now you're like, oh. I will say for the record, I want to give credit where credit is due. This provider did evaluate the patient and did order an appropriate workup. And so I want to give credit for that. I will say also that this person was admitted for infectious complications of intravenous drug use, was known to have bacteremia, and was known to have a septic joint. At the time of this exam, the patient had a heart rate of 150 and did later, this ultrasound did find a DVT in the affected arm. And so it is good that the provider assessed the patient and ordered the appropriate workup. What I really wish the provider had done was to keep the documentation just to what was pertinent. Look how much writing they could have saved themselves, right? The RN page stating the patient was complaining of severe pain. I went to the bedside to evaluate the patient. The patient was complaining of severe pain in the left forearm at the IV infiltration site. The arm's red and swollen. I palpated the site in question and the patient withdrew his arm with both gross, fine, and motor skills. He can move his fingers freely. I'm not concerned about compartment syndrome. I ordered the workup. Now, if you're the provider seeing the patient the next day, do you feel quite as grumpy about it? Like, no, not so much. You're like, oh gosh, he was sick overnight. I should check on him, right? And so our documentation will make people think things about our patient before they ever meet them. So I have a few tips about documentation. Please, please, please avoid judgmental phrases. Please stick to pertinent positives and negatives. Please stick to scientific facts. And please ask yourself, if you would be upset if you saw your words in your most beloved one's chart, in your most beloved loved one's chart. So what if mama was sick and she got delirious and she cussed out every nurse on the floor and threw her bedpan at them? Would you want to read that in your mom's chart, or would you want to read she struggled with delirium overnight? And then she threw the bedpan at me? You know, like I mean, it's traumatizing for us. And I will fully admit, like I get upset with patients too. Vent to your colleagues about it. If you need to talk to risk management about it because the patient threatened to sue you, talk to risk management, but please don't put it in their chart. Also, for the record, with the patient with DVT is now like almost 2 years into sobriety and like the most wonderful, thankful, grateful person who's very kind and polite. He was just incredibly sick right then. Actually, later got diagnosed with multiple PTE and lots and lots and lots and lots of illness from that bacteremia. But so that's my tips for documentation. and a reminder for us all. Again, my confession, I've been that provider who's documented those things. I'm now much more self-aware about it. So in summary, patients, be patient with your providers and explicit about your pain concerns. Providers, be patient with your patients and never wrestle with them. Instead, ask yourself, how bad must this patient feel to behave this way? And what else could be causing this pain and what can be done about that? And when you're documenting, please remember that your documentation advocates for or against your patient. And that is my summary. And I have lots of time for questions or comments. And yes, the person first language is huge. So instead of like, this is a former addict, this is a person with substance use disorder in long-term recovery. Because we are people first. Any comments or questions on those things, or any questions, more questions about pain management, etc.?
Hey, Dr. Leish, I think I saw a lot, there are quite a few comments, but the only question that I think came up is, do you have, and this, I don't know if Dr. Gooden would want to jump in on this either, but do you have any clinical experience microdosing of psychedelics, and do you have any perspective on this approach? I think that's the only question that came up.
So I'll give you my 2 cents, and then I'll say that Dr. Gooden, or if we had Karen Cropsey on here, she might also have some thoughts on that. I will say I don't have personal clinical experience because it's not, it's more of a research domain right now. So the patients who are being treated with this are being treated in research protocols, not in regular clinic practice. And I don't, our patients sometimes, we will recruit our patients to research projects, but we don't do the research here. And so I don't have so much experience with that. I will say my personal perspective on the approach is I'm all game for anything that might work. I'm excited about anything that might be helpful. I have a little bit of wariness about the generalizability of the initial studies. So some of the initial studies, like if you look at psychedelics for smoking cessation, it looks good. Like it looks like it might be helpful. But also if you look at those studies, they excluded a lot of people. And so people with histories of bipolar, schizophrenia, anyone with any serious mental illness, anyone with a history of substance use disorder. And so I'm not sure that even if we find that psychedelics are helpful for pain, if those studies will have included anyone with substance use disorders, and therefore will we per se know if the risks or the benefits outweigh the risks in that particular population. Dr. Gooden, I turn it over to you.
Just more on that topic, I would say it's one that's very much of interest, both now in the scientific community and in the general populace, if you will, all very, very experimental. You know, for the longest time, NIH, particularly NIDA, which is the National Institute of Drug Abuse, which I believe just changed its name to be a little bit less stigmatizing. But the point being is like, had a fundamental issue of funding work to use psychedelics to try to treat other things. And I think they've started to come around to that. So like, for example, now there's a trial at UAB where an investigator's using psilocybin, so the active ingredient in magic mushrooms, to treat cocaine use disorder. But again, all very experimental, all very regulated by the DEA, but then also by like the IRB, which is the internal sort of policing body for research for safety's sake, which is why, you know, you exclude individuals who maybe have more severe mental illness by history. So again, there's the generalizability piece or lack thereof that Dr. Leish spoke to. But certain centers, and you also have to appreciate that perhaps, you know, like everything being an adult, it becomes a little bit politicized. So some of these centers that are popping up to address things like psychedelics are in more northern states, and perhaps there's a fundamental issue, like say in more southern states, like say, for example, in Alabama, there's not even a terribly wide allotment of use of like say marijuana for things like treating pain. And don't get me wrong, there is now. That's been more recent in the last year or two, but it's not as widely available for things like treating chronic pain as in, say, Massachusetts or Illinois or something. To bring it back again, I guess my point is with the psychedelics is probably, I mean, I would say a decade or more away from being able to actually see that rolled out in any sort of clinical case, just because once it stops being so experimental and maybe it becomes a little bit more mainstream, again, then there's probably going to be some level of pharmaceutical involvement in terms of how can this be prioritized, proprietarized to make money, what have you, because this is the healthcare system we live in, so forth and so on. You see what I'm saying? So that's a long-winded way of saying, no, not yet.
Awesome. Thank you. Yeah. And there's a couple other comments. I was just going to say, my own experience, life experience, whatever you want to call it. And this is just anecdotal, of course, and very unscientific by comparison to everything else we'll be talking today. But I, being someone in recovery, I have a solution that I don't need to take substances, but I have experienced through psychedelics in my past, when I was just in my past, not in recovery, a lot of relief from certain things that I had never experienced relief with more traditional kind of medicinal methods. So I am all for it. That's my personal opinion. That's not APC's opinion. And I really look forward into the future. I'm very curious to see what more robust research shows just how helpful it could be and who it could help and what it could help with. So there's somebody patiently waiting with their hand up, Crystal. Crystal, well, the hand is down. 0 for 2 today. The hand is down.
She raised it again. She raised it again.
Yeah. Okay. All right. So there it is. Crystal, I'm going to push allow to talk. I'm pretty sure that's going to open your camera. I'm not sure. So just be prepared for that, but here we go. All right. So yeah, the default was camera off. Crystal, you are now able to speak.
Okay. I live in a very rural community. And it is really, I don't know, it's really good to hear that there is so much open-mindedness in the pain medication. Yet in your area that you're speaking of, because here it's almost as if I live in Southwest Virginia, and with the huge opioid crisis in our area, it's almost as if the doctors seem to be punishing all of us because of it. And I just, whether we have had addiction problems or not with SUD, I'm just wondering if this is something like seeing across the board, because I kind of feel like here in our area because everybody knows everybody. So in our area, when you go to the doctor, you have, certain surgeries or whatever. Sometimes they just don't even write any prescriptions. And I don't know, I feel like it's such like a punishment or something for this area, because there doesn't seem to be as much open-mindedness as what I've heard all morning. And that's just refreshing to hear that people really care, because it seems like they don't here.
Yeah, and I'm sorry that you're having that experience, and there certainly has been huge shifts, and that's also my usually it's part of my confession, because I was one of those doctors who was like, these pain medicines are crazy, I don't want to prescribe them anymore. But then but I didn't just stop prescribing them, but I actually got into this line of work because in my primary care practice, we had the walk-in clinic. So patients who were having acute issues showed up in our clinic. And I can't tell you the number of people in their 50s, 60s, 70s who had been on opioids for 10, 15, 20 years, who after the 2016 guidelines had their prescription abruptly stopped and showed up in our waiting room in full-blown opioid withdrawal with high blood pressures and diarrhea and everything, and they're like in their 70s. And they may or may not have had any aberrant behavior. And so learning how to manage that became critical. And so I know kind of the conundrum of provider bias. I will say that that's why I'm such an advocate of using the things that are science, that are evidence-based and validated. So, right, like the opioid risk tools, a validated assessment, the COM is a validated assessment. Those guidelines for opioid prescribing after surgery, those are also guidelines, right? And so the providers would not be getting in trouble for prescribing opioids after hip replacement or something like that. And I also, to kind of talk toward Edward's point of being able to manage his pain with non-opioid measures, I think that's great. I love managing pain with non-opioid measures. I will say it's also a risk for relapse if someone has a huge surge. Like if one of my patients is going in and they're going to have knee replacement and they're like, well, I don't want to take any opioids. I'm like, well, that might be an unrealistic expectation and one that could set you up for relapse. Because then if you get sent home or if they're on it in the hospital and they're like, well, I don't want to go home with it. Then you have to go home with no opioids and it's Friday and you can't see a provider until Monday. What happens over the weekend can be a huge problem for relapse.
I kind of seem like that the giving other options of pain management that Edward was talking about. I mean, I don't know what he does, but I mean, it's almost as if they're not giving us other options here. And yeah, I don't know. I don't know how to discuss it with them. Because some of it is with family members who are older, and it's almost like I don't understand why they're given no other options to control their pain meds. It's just like, no, go home. I don't understand this in this area. This is where I've mainly seen this happen.
Yeah. And I think that becomes a lot of the providers feeling burnt. And so when they hear someone's in pain, they hear, I want opioids. And they're
Exactly.
like, no, I'm not doing that. And I mean, and even my family's in South Florida, where they also had a huge problem with sort of pill mill clinics. And my sister was having shin splints, or like really bad. She had to stop running. And she went to the doctor and they did an x-ray and she's like, Leah, I know it's not broken because I can run on it. She's like, but then they told me nothing. And I was like, here's what you're going to have to do. You're going to have to go to the doctor and you're going to have to say, my leg hurts. Can I please be referred to physical therapy? She's like, because they just told me it's not broken. I already knew that before I walked in. I was like, Sandra, they just think that you're asking for opioids because you're young and otherwise healthy and you say you're having pain that they can't explain. And so sometimes it unfortunately becomes the burden of the patient to say, what are the other, I understand I can't have opioids. What are these other options? And that's just a part of our own biases.
Very important topic. I would just say to Crystal's question and anybody sort of wondering about this, the push for new and different and better pain management medications, techniques is an ongoing quest, right? Like it's a high priority for the National Institutes of Health to try to fund and help investigators to come up with things that can be brought to clinics. But recognizing that in certain instances and for certain individuals, what have you, opioids, are still a consideration. Back in the early 2000s, I like to think of it as a pendulum, right? The thing that swings back and forth, right? Back in the early 2000s, the pendulum was way in the direction of here's opioids, the wonder drugs. Let's give them to everybody, right? For what ails you. Mostly pain, but hey, you're having trouble sleeping, have an opioid, right? You're not feeling so good, have an opioid. So, and then what ended up happening, right, is that there was a lot of the fallout related to, say, Purdue Pharma pushing a lot, and it was with OxyContin particularly. And then, things like the Drug Enforcement Agency and things that are related to drug enforcement in the United States started to take notice, right? And, in that regard, there was a crackdown, and then all of a sudden that pendulum started to swing such that there was way more oversight for providers, particularly prescribing providers, what have you. And it got to be real scary, for a lot of providers. And it's not necessarily that certain providers wanted to punish anybody, but they were like, I have to weigh being able to prescribe an opioid versus like losing my license and my job and not being able to take care of my family anymore. Real scary stuff, right? So there was a lot of folks who just jumped ship and they were like, I'm just going to go practice medicine some other way, shape, or form. That left a lot of patients stranded, right? And perhaps now the pendulum is starting to maybe move a little bit more towards center of like responsible opioid stewardship, or like responsible prescribing on behalf of providers, but also responsible use of these medications on behalf of patients. And it'll be interesting to see, I'm not sure if folks are familiar with the United States Supreme Court just recently ruled on a case. It was called the pill mill case, where ultimately the Supreme Court justices, all 9 of them, were all in favor of saying that like a physician's intent matters, right? So to the extent that like the provider's intent was to try to do good, right, was to try to actually treat pain or do right by their patients, right, that they can't just be, have their door kicked in and be called a pill mill and then face prosecution for that. There's more nuance in it, and I'm still getting familiar, but it'll be interesting to see, this response to, again, the pendulum being swung way back in the other direction of no opioids for nobody at any time whatsoever, to what extent that helps bring it a little bit more to midline, where it's like, granted, not everybody is appropriate for this medication at any given time for whatever their reasons may be, but some folks are, right? And in what circumstances? Then it's always an ongoing collaboration between patients and provider, recognizing that last month ain't the same as this month, and so forth and so on. So we have to be, smart together about these things. But all that to say is that hopefully it will make things better, particularly in, say, a place like Appalachia, where Crystal was referring to living, like in Southwest Virginia, the foothills of Eastern Tennessee and Western North Carolina on down, where a lot of times, those providers don't necessarily have access to the other sort of pain management mechanisms, like good physical therapy or pain psychology or acupuncture, massage. They may just have access, prescribing that they can do, so what do you do in those instances, right? So again, that's also something that resonates with folks now, is that particularly in those rural areas, that that's a priority area where folks may be particularly vulnerable for a myriad reasons that aren't necessarily their own. Yeah, lack of access. What do we do to build access, right? And that may even just be like, say, a provider working in that rural area having access remotely to a team of other people that they can consult with. And those are called generally like ECHO sorts of projects, which are meant to sort of funnel resources and expertise from, say, a place like UAB, which is in Birmingham, Alabama, out to, the southwest of the state, whatever, where it's also very rural. Does that make sense? I'll stop there because now I'm just biting.
No, awesome. Thank you. So I just want to thank you, Crystal, for asking that. I'm going to, because we've had somebody else that's waiting with their hand up, I'm going to disable you, Crystal, but we still love you. So
maybe while you enable the next person, I'll answer the question in the chat super quickly. So
okay.
Is tramadol considered an opioid?
Yes.
It's a fairly low OME or oral morphine equivalent opioid. So not all opioids are the same. 1 milligram of morphine is like half to 0.75 milligrams of oxycodone, or I'm sorry, which is equal to like way like under like an eighth of a milligram of buprenorphine, and so tramadol is less than 1 milligram of morphine.
Gotcha. Thank you.
And can people have slides? I'm absolutely happy to share my slides, Edward. You will notice, well, I don't know if you can't tell. We were on slide 48 of 70. That's because I had a lot of things that it's such a big topic and there's so much to think about. I had a lot of slides that I chose not to present today. So when you get your copy of the slides, just know you get a lot of bonus material. And don't judge that it's all unorganized at the end.
No worries. Thank you. Yeah, I would just mention too, and there will be a recording available. Several people people have asked that. But on Dr. Gooden's point, I actually appreciate that the pendulum has swung into the more conservative approach, because I think there's less risk involved ultimately with that approach, and kind of slimming it down to where it's a more concentrated and I'm going to use this word, responsible use of opioids versus just the throw them all, throw opioids at everything. But okay, Michael, you are up, my friend. Michael B, you are now, not sure if he knows he still has his hand up. Mike, there we go.
Can you hear me now?
Yes, sir.
Okay, I'm a parent of 2 addicted children to heroin and fentanyl. It's been going on for about 6 years. It's been a very devastating journey for my ex-wife and myself. This is the number one.
Oh, Michael, I think you accidentally muted yourself there. Let's see.
Can you unmute him?
Well, it's, I can ask to unmute. I don't know if I have the authority to, I'll do that. Ask to unmute. Hey, Michael.
He's back.
Yes, I'm back. It's my
Okay.
phone rang, and apologies to you.
No worries.
Can you still hear me?
Yes, sir.
Okay. I'm actually starting a nonprofit organization, and to actually be an advocate for other rehab centers, provide resources such as this, which this is incredibly informative. I'm soaking it all up. But I have 2 children currently addicted to fentanyl and heroin, mostly fentanyl. And my ex-wife and I, we're concerned every day of their life or death. How do we get the WANT into that mind? Because that is the number one question, because we have tried every single thing. Now, it sounds like a lot of this discussion is more pharmacology, where we're providing substances to help curb the addiction into hopefully an end place of sobriety, correct?
Yeah, and so again, this wasn't like a comprehensive talk on substance use disorder treatment, or particularly opioid use disorder treatment. But I think if you're looking for non-pharmacologic stuff, Dr. Gooden is going to talk about non-pharmacologic interventions for pain later.
Okay, I have a second question as well. Y'all previously talked about psychedelics, and John Hopkins has done research on psilocybin, which is only prescribed in areas like Colorado, California, and the like, and they've seen incredible results with that particular treatment. And I know there were some comments which I missed about that particular drug. What are your thoughts on that again, if you could reiterate?
I think a summary of the thoughts would be, we are hopeful for anything that might offer some benefit, including psychedelics. That research is probably at least a decade away.
A decade away. Do they have a right to try?
In a clinical trial.
In a clinical trial, but
So
I mean, I couldn't fly my kids up to Colorado and try this experimental drug.
It's presently only being prescribed through clinical trials.
So they would have to be a part of that trial.
Mm-hmm. And the best way to
Okay.
find those is if you look at clinicaltrials.gov, you
Yes,
as
ma'am.
a patient can actually go in and search the topic.
Okay. Our problem is getting the want, and as parents, sometimes external help is where a lot of impact can be made. As parents, I was an ex-addict in my 20s and drank alcohol for 20 or 30 years. I've just recently found out I have PTSD as a result of all this, and that's being treated, and it's working very, very well. But dealing with this issue, that compassion and empathy, we're at a point now where it's a life and death situation, and we've got to make certain moves right now to try to get that WANT inside their mind so they can get the help they need. Now, our youngest child was on Suboxone, but would not take it regularly as prescribed. He lived with me, and I had to manage that and hide that in my place, so he never went out to try to sell it or whatever. You know, that's the problem. Their love is for this other drug. So,
If you're,
you know, we're stuck.
Yeah, I was just going to mention, Michael, I think, and I promise I'm not trying to cut you off. We're running on a somewhat tight schedule, but what I was
Yes.
going to say was, I think what I'll do is I'll send you a message with my cell, and I can talk to you more about as far as working through the active addictions with your children right now. One of my roles here is I am a certified peer, and obviously someone in recovery and all that. And I'd love to talk to you more. I think.
Okay, sounds great.
Yeah. So I will.
Thank you very much.
Absolutely.
I apologize for the time.
No. You're perfectly good. It's not. I hated doing that, but I just want to make sure we stay on schedule. So
Yes, sir. Thank you, sir.
I appreciate you joining, Mike.
Yes.
All right, so that is all the time we have. I think that's all the questions. Let me do that.
can I say one last thing about my slides?
Yeah,
Really quick.
Yeah.
I'm perfectly happy sharing my slides with anyone. I don't mind if you like print certain slides and give them to patients. I do ask that you not publish them online anywhere. And that's mostly because I'm pretty certain that I got every single image from a Creative Commons license website, but I'm not 100% certain. And so just in case I accidentally included someone's trademarked license, like I'm certain for everything that's in the slides that I presented that I have license for that. But in the bonus material at the end, I just don't want to violate someone's copyrights on accident.
Yeah, awesome. Well, I got to tell you, Dr. Leish, I know you mentioned earlier a little bit of maybe apprehension and kind of things weren't as crystal clear from on my end for you, but that was incredible. Your presentation was fantastic. Awesome. Thank you very much.
And let me clarify, it wasn't that you weren't clear. It was that even hearing what you said, I was like, oh, I want to talk about this. And that's why there's like over 70 slides. And that's after I deleted some because I had so much I thought was important.
Yeah. Awesome. Well, that was tremendous. Thank you very much.
Thank you.
Perfect. All right. So what we're going to do, Dr. Bradford just joined, but we are going to break. All right. Welcome back. It is now time for Dr. Bradford's presentation. I'm going to jump in and mention that, yes, that was a typo. It was meant to say not Hispanic, not hot Hispanic. So I apologize for that. But it is supposed to say not Hispanic. Again, apologies. But we will press forward and Dr. Bradford will go ahead and begin his presentation.
Thanks, Edward. I was going to share my screen. I think it's disabled.
Okay, 1 second. I will co-host you. Let's see if I can. Here we go. There you go. Does that work? Yes.
Yeah,
Okay.
perfect.
Awesome.
All right, welcome everyone. I'm Davis Bradford. I am a physician here at UAB Hospital. I also work at the VA here in Birmingham. I'm a internist and also board certified addiction doctor. I'll be speaking today about harm reduction and relapse prevention, and specifically focusing on patients with opioid use disorder that are facing acute pain. I work primarily in the hospital on our addiction consult service here at UAB. And so many of these are informed by experiences with patients here on our consult service. I have no financial disclosures. I'll use trade names briefly for some drugs, mainly to do so to reflect the names by which you may know them or by which patients may refer to them. I'll usually default to the generic name though, rather than using brand names. So the first thing I'd like to do is to meet you. And so this is going to require a little bit of your participation. So if you will hover toward the top of your screens, Edward, I'm not sure if participants will be able to do this, but we'll have to try it out. If you hover toward this top of your screen, you should see a sort of a menu bar. If not, someone can just unmute themselves or put in the chat. And you should see a view options menu, and you can click annotate. And then you can hover over a stamp and select an icon. It can be the star icon or another icon. Gotcha. Edward, is there any way to temporarily allow like audience hosting? I think it's only able for if not, that's totally okay.
Let me.
It's showing up on my screen, but I think it's only because it's a host feature.
No host.
If it's too complicated, we'll move in.
I think we'll just have to move on. That's my fault.
No worries. Well, welcome everyone. This point of this exercise was to, number one, see where you're from and where you're joining. If you want to put in the chat where you're joining from, we have a lot of people here, so I'd love to get to meet you all, but for the sake of time, if you just want to put in where you're joining in from, that'd be great. If you're and sort of your role. Great. So we have people from all over the state. I see people from out of the state as well. So welcome. Specifically looking at the state of Alabama, you see a map here broken down by counties, and you can see that some of the counties are in different shades. And the chances are that if you're joining us from Alabama, you're from a county with a high need for addiction treatment. And this map shows a map of the US, and it shows dark green counties as being those in highest need, and that's defined as getting in the 80th percentile in two of the three measures listed here: drug overdose mortality, the non-medical use of opioids, or high rates of opioid prescribing. And you can see here that there's a number of highest need counties here in Alabama. So welcome to everyone who's joining. So roadmap for today, we'll first begin by just talking about what is harm reduction. We'll then go into overdose education and naloxone distribution. And the bulk of our time will be focused on providing harm reduction and preventing relapse at the intersection of pain and opioid use disorder, really specifically diving into a few cases. And we'll really be asking you to participate during those case discussions. So we'll start by thinking about what is harm reduction. And so I'd like to turn it over to y'all to see what comes to your mind when you hear harm reduction. Feel free to participate in the chat or to unmute yourself to kind of think about when you hear the term harm reduction, what does that mean to you? I love it. Xavier says seatbelts, one of a very public health measure of harm reduction. What else comes to mind? I really like this, decreasing hurt and increasing wellness and compassion. We're seeing a lot of different types of harm reduction here, and I'm glad you're all thinking very broadly, and that harm reduction, though it's a term that you often hear in the addiction community, that it pervades our whole public health system, and that it's really a global approach that we take. And so before we kind of deep dive into sort of the definition of harm reduction, I'd like to turn back to overall health and what factor most contributes to a person's health. And this will be an audience poll. Edward, I'm perfect. And so if you just participate, you have a poll here, and if you'll just click on what you think, which of these factors contributes most to a person's health. Give a few more seconds for people to participate before ending the poll. All right, let's end the poll now. And the results, can you share the results, Edward? Is that possible?
I hit share results.
Okay, perfect.
Sure. Yeah.
Okay, so we got over half of the participants picked behavior as the thing that contributes the most, with a quarter coming in with the healthcare they receive and genetics. And if we look at some of the work that's done in this area, this is a study out of the New England Journal back in the 2000s that looked at different factors to premature death. And you can see here that the two takeaways that I'd really just like to emphasize is that the healthcare someone receives contributes very narrowly to premature death. So it's, we think we do a lot as physicians, but it's much more about the social determinants of health than what's happening at a public health level. And that there's also a large contributor of behavior contributing to early death. And I'd really like to focus on that behavior as a fundamental contributor to health, and that behavioral modification is a necessary part of healthcare and how we can influence wellness for our community. And if we think about harm reduction on the spectrum of behavior, thinking about behaviors that are unhealthy or unsafe, and a spectrum of those that are healthy and safe. And you can see here a few examples of different behaviors and different ways we can restrict behaviors. And you can see some examples here. And you can see that there's on sort of the far end of either extreme. And that harm reduction is really about moving from unsafe to safer and unhealthy to healthier. And it's not always about moving to the extreme. It's sometimes the elimination of risk is not always practical or necessary. And you can see here some examples of harm reduction. And you all listed a great number of aspects of harm reduction that aren't about complete elimination of risk. They're about something in the middle that is safer and healthier, that isn't on the sort of far end of the spectrum. Sometimes in the addiction world and as an addiction provider, I hear a lot of healthcare providers and other even patients in recovery thinking of using this terminology about enabling and equating that with harm reduction. I like to emphasize a few core principles of harm reduction and really point out this isn't enabling in any way. And so these are core principles of harm reductions that I'll go over. So the first principle is humanism, that as providers, we value, care for, respect, and dignify patients as individuals. The second core principle is pragmatism, in that health behaviors and the ability to change them are influenced by social and community norms, and they don't occur within a vacuum. Third, individualism. People present with spectrums of harm and receptivity, and it requires a spectrum of intervention options. Fourth, this is a principle that we hold dear as a medical community, is autonomy. The individuals ultimately make their own choices about treatment. As a primary care provider, this is one that's near and dear to my heart, is incrementalism. Any positive change is a step toward improved health, and positive change can take years. And so it's really not about huge strides, it's sometimes about baby steps. And lastly, accountability without terminations. And this is something that I think is really important when we're thinking about harm reduction and also addiction care, that patients are responsible for their choices and health behaviors, and that we are there to support and offer accountability, but it's not our role to terminate that relationship in most relationships. So now that we've talked a little bit about harm reduction, I'd like to take a brief aside into one core principle of harm reduction for patients with opioid use disorder, and that's overdose education and naloxone distribution. And naloxone is an opioid antagonist. It reverses opioid overdoses and saves lives. It's one of the core parts of harm reduction that we provide to our patients with opioid use disorder. And so thinking about who should have a naloxone kit. So the CDC back in the early 2000s and then the 2010s released guidelines that patients prescribed over 50 oral morphine equivalents a day should have a naloxone kit. And those co-prescribed opioids and benzodiazepines should have a naloxone kit. And then lastly, patients who use non-prescribed opioids should have a naloxone kit. But I'd really like to challenge us to think more broadly about that we should really get naloxone more into the community, and that friends and family of patients with opioid use disorder should have naloxone. That patients who use stimulants, as we're increasingly seeing stimulants like methamphetamine and cocaine being contaminated with fentanyl, that patients who use these stimulants are inadvertently exposed to fentanyl and are suffering from overdoses. And it's really important that even with patients without opioid use disorder that are using other recreational substances, to get naloxone in their hands and educate them about this danger. And then lastly, anyone that may need to respond to an opioid overdose. And I would say that we're in a public health crisis, and the overdose crisis warrants that everyone should know how to use naloxone, and that it should be as widely available as we can make it. And so you may be asking, where can I get a Narcan kit? So the last thing before we'll move on to where you can get a Narcan kit, I put Buddy to Elf here. So it's always important when we're talking about Narcan to remember that if an overdose happens and the patient is alone, that the naloxone kit isn't going to be able to be used. So it's really important to counsel patients to be with others when using, and that to really counsel family, friends, and trusted partners to be able to use naloxone, because it doesn't do good if the patient's by themselves. So where can we get a Narcan kit? Here in Alabama, the Jefferson County Department of Health can provide naloxone throughout the state. So not even if you're not a Jefferson County resident, non-residents of Jefferson County, so those from other counties, can get a naloxone kit through the health department. This is a QR code to their website. It goes through, there's an online training that they have available. And then after participating in that online training, you can get a naloxone kit mailed after participating in that training. So feel free to explore this at your own time. The other resource that I like to share with patients and friends and family members is the Never Use Alone hotline. And this is a hotline that takes a patient's, a person who's using drugs, first name and current address in case they get disconnected because of an overdose. Help is sent. So this is a resource you can share with patients that use drugs, and really empower them to, if they can't have someone there, that this is at least one backup mechanism. So after we've now kind of talked about some aspects of harm reduction and went into naloxone distribution, I'd really like to turn the rest of our time into providing harm reduction and preventing relapse for patients that have opioid use disorder and are facing this intersection really of acute pain. I'll be asking for Edward's help to help kind of moderate, and we'll be asking for your participation as we go through some cases together. The first case, we'll be talking about a 45-year-old man with opioid use disorder in long-term recovery, is hospitalized after a motor vehicle collision in which he sustained a left femur fracture. He has a past medical history of chronic hepatitis C infection and tobacco use. He takes no medications. He's married with 2 kids, and he has a sober home environment. And so thinking about this gentleman coming in and sustained a left femur fracture, I want us to kind of fast forward and think about this after recovery, what happens when we discharge this patient, and if when discharging this patient after surgery, would you prescribe opioids for acute pain? Okay, I see that we have roughly about the same as previous polling, over 50% coming in with around, we're going to share results. So pretty evenly divided. Most people said yes, but again, 40% said no. And so I just want to explore this, and I'm just going to put the case back up for people to reflect on. And Edward's going to be asking some questions, but before Edward asks some questions, I'd like to talk about, get some feedback from the audience about their thought process into answering this first question, and how you would approach that. So feel free to write in the chat or unmute yourself to kind of tell me exactly what you're thinking when you answered yes or no.
And you can utilize the raise hand feature, and that will allow me to, if you want to talk instead of put it in the chat box, and I'll see it and I can unmute you. All right, Robert got his hand up just before Meredith and Crystal responded. So Robert, I will go ahead and unmute you. Let's see, here we go. All right, Robert, you are now able to speak.
Okay, yeah. I would say no, I wouldn't prescribe opioids for his for his physical injury due to his past history with opioid use disorder. It could be a possible trigger, could lead back to relapse, so that would be the main cause of concern right there, as a factor of him, getting back on opioids again, because he does have a long-term recovery, so that definitely would be a major trigger for him, I would say.
Excellent. Thank you, Robert.
Hmm?
Thanks, Robert. I'll just, if anyone else wants to raise their hand, I'm going to just reflect on some of the things that Robert said and also what has been placed in the chat. So Robert raised the concern that having opioids would be triggering. I also see that there are some folks that also thinking that the unmanaged pain could be triggering. And I think both of those are very important to acknowledge, and both of those things can exist simultaneously. And that it's not always an either or situation, and that it's really about this, that both of these things can be very triggering, and that it's really about partnering with the patient and kind of thinking through what may be best for him or her. I would, caution against a blanket hard no for patients in this situation, and that it's really, quite appropriate for someone with a femur fracture that just went through major surgery to have opioids, and that we do have some evidence for different surgeries and when they may warrant opioids and for how long they may warrant opioids following surgery. And so I'm going to come back to the chat in a moment. Before I do that, I'd like to just go over some evidence-based durations for discharge opioid prescriptions. And this is for opioid prescriptions in general, not necessarily for those patients with opioid use disorder. So again, this is in general. And so again, you see sort of three big buckets of different types of recovery following different types of procedure. And so type 1 is when you expect rapid recovery. This is most oral or dental surgeries, smaller laparoscopic surgeries like an appendectomy, where the appendix is removed, or gallbladder is removed, or even a thyroidectomy. These don't always require opioids after discharge. They may require certainly opioids during the procedure and immediately following, but they don't always require opioids the following, and that the expected duration of opioids is really less than or equal to 3 days. And so again, these are smaller surgeries, and then we move on to sort of larger surgeries. So these are major joint surgeries, removing like a part of the colon, a laparoscopic hysterectomy, so removing a larger organ, or a cesarean section. And here we see that this may require slightly longer opioid prescribing because the length of recovery is expected to be longer. And that really that 7 days should be sufficient, but if extended, this should be done, as many of you mentioned, with very close follow-up, and that if extended, it should be done with close follow-up and definitely tapered by 6 weeks. And then the last, we see some more major surgeries, and really those involving the spine, very large joints, abdominal hysterectomy. So these are open surgeries, are cutting up into the thorax in any way, so a sternotomy, any lung removals. These will require longer opioid prescriptions and are quite painful, but typically recover within 2 weeks. And that if opioids are required for longer than that, again, it should be done with close follow-up, and that these are ideally tapered within 6 weeks as the pain and the healing process kind of resolves. And so I just want to reflect and make sure that there's no other comments or things. I'm going to be reflecting on some of the comments in the chat. So I think a few other considerations that all of you highlighted, that he has a sort of sober, supportive home environment. And I think that's one thing that I frequently look for when I'm talking with patients, is what their home environment is like. For patients in recovery, I often ask if they have a sober support that can help administer medications and help hold them accountable. If they're engaged in peer support groups and have a sponsor in those peer support groups, it's also encouraged, if they feel comfortable, sharing that with their sponsor and having sort of a safety planning in place. And so it's really about creating accountability, and then having multiple layers of protection. As you've all highlighted, that both the pain, but also having the opioids themselves can be triggers for relapse.
Did you want me, want to go ahead and work through some of these questions I had, Dr. Bradford?
Please.
Okay. Okay. So the one thing that came to mind, and I was nodding my head when you mentioned it, myself and some of my friends in recovery, when they have had, I haven't had to go through this, thankfully, but some friends who are in recovery and they did have something come up medically where opioids were indicated, they had a thorough plan in place, and they were able to go through it just fine. And that's something that is, of course, the patient's responsibility, but I think it would be helpful for the provider to engage the patient in that and kind of explore, what is their, like you said, Dr. Bradford, what is their home situation, their recovery situation? Do they have somebody that they trust to hold and administer the medications as prescribed? All those little things. But the first question I had for this case, for the gentleman who is in recovery and breaks his femur, when you first, maybe not when you first, but in your first couple of interactions with this patient, if they're lucid and they're able to speak with you and they're not in agonizing pain, do you suggest discussing with them their stance on narcotics and opioids first, before going down that route, or kind of as they're administered? What would be your thoughts on that?
Edward, it really depends on sort of the context and how the patient comes in and how much sort of notice we have about a surgery and how much planning can go into it. Mm-hmm. I think for planned surgeries and elective surgeries, I really, the patients face a lot of stigma, even from healthcare providers around this topic. I think that with a trusted healthcare professional, that planning for the surgery and planning on how that patient's approach to opioids is going to be taken can be really helpful. And so I would encourage an open conversation as early as possible, mm-hmm. And being realistic about the type of surgery, and having some of these evidence-based knowledge about sort of what is expected of a patient without opioid use disorder, for them to factor in what kind of pain may I be facing and how can I think about the expected recovery for me. Yeah.
Sure. And I think my next couple of questions are probably, or this next one for sure, would apply to this type 1 expected rapid recovery, but because it says not always necessary, what are some circumstances that providers should look for when they're opting for non-narcotic pain management, when they're not really sure, but they decide to go that route?
So especially for these smaller procedures, and even I would also include different medical conditions that cause acute pain, that sort of the older way of thinking is that these all required opioids, and we're learning more and more that that's simply just not the case, and that non-opioid therapies such as non-steroidal anti-inflammatories at high doses can be really beneficial if there's not contraindications. And short courses for the majority of patients are going to be very safe for non-steroidal anti-inflammatories like naproxen and ibuprofen. And so like things like a kidney stone, there have been studies looking at managing those with non-steroidals at appropriate doses. And I'm not saying that we may not require opioids, but I think that both patients and providers can adjust expectations and create some openness that there may be other options to consider that could be opioid sparing in that approach. We see a lot of dental procedures that have opioids prescribed, and I would say that's by and large, they're prescribed way longer than 3 days for a lot of times, and that's really not appropriate, and it's really creating harms not only for patients with opioid use disorder, but for those patients without opioid use disorder as well.
Excellent. And this, you might could see this as, or interpret this as kind of the opposite of my previous question, but what are some thresholds maybe that providers would look for, which would basically indicate to them that opiates might become necessary for treatment, when it's kind of in that area where you're not exactly sure, but this or that circumstance comes up and it helps them decide that, okay, maybe we need to try opiates.
Mm-hmm. So I think the type of surgery is definitely going to influence that. I think for a patient in the hospital, my approach as an addiction provider, but also as an internist, is to sort of optimize non-opioid therapies first, even if we're adding opioids, to make those as needed medicines, but to really make non-opioids scheduled. And that as we approach discharge, if the patient's pain is really just not being managed well, that we need to really find a way to sort of strike a balance and have close follow-up. And so it's really about sort of what happens in the hospital and really maximizing those non-opioids before we start adding on lots of opioids.
Excellent. Okay, so the last one, and this one is back to the patient in case one. So let's imagine that in this case, the patient is he insists that he doesn't receive opiates, but it is absolutely necessary. What are some strategies you could use to help maybe soothe the patient? I mean, for example, do you think it would help to start with small doses and explain to the patient that you're confident that because their body needs it so badly that they're going to get pain relief and very little euphoria or narcotic effects, despite the fact that they have opioid use disorder? Do you think that would be one of a few good strategies?
Yeah, I think really kind of diving into what's driving that concern for the patient and seeing sort of what's behind that sort of stance that the patient's taking, and really, working with the patient to see if there are these ways that we can introduce opioids slowly in a monitored setting. And so I use that we're in the hospital and we're in a monitored place here, and so we should use this time around surgery in the hospital as a way to prepare for when you're out of the hospital. And so I think that the safety of being in a monitored setting can provide patients comfort, and really just partnering with them to give them some control in a situation where a lot of the control has been taken from them.
Excellent. Thank you. Those are the questions I had for case one.
Great, thanks, Edward. So we'll move into case 2. So this was a 37-year-old woman with opioid use disorder. This patient is in recovery, is on buprenorphine, naloxone, or Suboxone, has anxiety and obesity, and is preparing for a planned upcoming cholecystectomy after a recent hospitalization and recovery from gallstone pancreatitis. So she's no longer in pain from the pancreatitis. She's been discharged, and it was recommended to have her gallbladder removed in the upcoming weeks following this discharge. Her past medical history, she last used illicit opioids around 12 months ago, so it's been in recovery for 12 months. Her home medication, she's on buprenorphine naloxone. She's on 60 milligrams daily. Again, the dosing here, we normally are just thinking about the buprenorphine as the active ingredient. If administered sublingually, that's the only active ingredient. The naloxone is not absorbed sublingually, and so it's really not the active ingredient. So the buprenorphine, I'm just going to be referring to, she's on 16 milligrams daily, and she takes two tablets of that sublingually every morning, and doing well without cravings. Social history, she lives alone, and she's a manager at TJ Maxx. And so it's a week before the surgery, and we had the luxury of some time here, and we want to prepare for what to do with her Suboxone. And so I have some choices here about, you can either discontinue the buprenorphine, you can rapidly taper off the buprenorphine over the next week before the surgery. You can lower the buprenorphine dose to a lower dose, 8 to 12 milligrams, or to continue the present dose at 16 milligrams. Okay, begin in there and share the results. So by and large, most people wanted to continue the buprenorphine. Got 75% wanted to continue buprenorphine at some dose, with a quarter of you wanting to either discontinue or taper off. And I want to just highlight that this is there is a I'm going to give some recommendations. This is buprenorphine management in a perioperative period of around surgery has drastically changed over the last 10 years. And I'm just going to be talking through some factors that I consider when I'm approaching what we do with Suboxone preparing for surgery. But before I do that and get into sort of why I may choose one or the other of these, maybe if someone can volunteer to, from either the discontinue or the tapering off, to volunteer sort of why they chose that. Thank you in advance for putting yourself out there. You can do it in the chat, or if you want to raise your hand where Edward can let you speak to the group. So Crystal, you spoke out in the chat, so thank you for that. You chose to rapidly taper off. And so there's this, you would be sort of among providers that a lot of people take this approach about tapering off or discontinuing opioids before surgery, because there's the concern that buprenorphine will block the opioids required for surgery. And that even if the patient, this is a laparoscopic gallbladder removal, which is in sort of the type 1 surgeries that is a pretty fast recovery and that doesn't always require opioids for very long after surgery. It's definitely going to require opioids during the surgery for sedation and analgesia during the surgery itself. So we definitely have to think about that at least, regardless of what sort of happens in the postoperative period. And so there's this notion that buprenorphine is going to block out all the other opioids. And so that's a well-informed notion, because that's why we use buprenorphine in a patient with opioid use disorder, right? Number one, it's going to relieve cravings by its agonist effect. And it's also binding very tightly to the agonist and helps prevent other opioids from creating a euphoria. And so it does have a blockade effect. For a long time, we've removed patients off buprenorphine. However, for patients in recovery, this can be really destabilizing. And so number one, if we discontinue or rapidly taper off, we jeopardize the patient going into opioid withdrawal because of that. And then even if we avoid that by giving opioids around the perioperative period, we still run the risk of the patient being triggered by increase in cravings. And so my general approach is to continue buprenorphine perioperatively. But I do want to go into why or why not you would choose C or D. And so in general, if you continue buprenorphine at doses of 16 or higher, you are having most of the opioid receptors occupied by buprenorphine. So you're really not leaving much room for other opioids to actually work. And so what I generally advise patients to do, in general, we want to do this 3 to 4 days in advance of the surgery to allow some of the buprenorphine to leave, is to lower the dose of buprenorphine before surgery. And so to do this in advance, because buprenorphine has a long half-life, to give some of the time for buprenorphine to leave, to free up some of those opioid receptors for full agonist that we use in the hospital to actually work on those receptors that aren't occupied, while still allowing buprenorphine to be present at low amounts in the background. The other risk we run by totally discontinuing buprenorphine is that when we restart buprenorphine, we run the risk of what's called precipitated opioid withdrawal, which you may have heard about. It's when buprenorphine is introduced when full agonists are present. And what happens is buprenorphine, since it has a higher affinity than most other opiate full agonists, it will come and displace all the full agonists. So for a patient that's using heroin, for instance, if we introduce buprenorphine too early and there's too much heroin still in the system, it displaces all that heroin, knocks the heroin off the receptor, and a patient feels withdrawal. And so we generally, when we're starting buprenorphine for a patient, we let them enter mild to moderate withdrawal before starting buprenorphine. And so that same thing can happen during surgery. When we totally take off buprenorphine, we then put full agonists on the receptors, we run the exact same risk when we are choosing to restart buprenorphine following surgery. So again, this is why my approach is to generally continue buprenorphine at a lower dose. Number one, to prevent withdrawal and increase cravings. And number two, to on the back end, to avoid having to worry about precipitating opioid withdrawal. Again, there are many different approaches to this, and it's a pretty nuanced discussion, but I did want to open this up as an opportunity to think about that buprenorphine, as we used to think, doesn't have to be discontinued. I've had patients that have had open heart surgery, had valve replacements, that have gone through surgery and had their buprenorphine continue quite successfully with good pain control. I'm going to turn it over to you, Edward, for further questions before we move on to some more polling.
Yeah, the first one I had was when I was thinking about that, the possibility of precipitated withdrawals. As someone who has experienced those before, they are certainly to look to avoid those at all costs. So if the person, or if this patient, if she wants to resume her MAT or her MOUD after the surgery, and were to presume that during the peri-op period they were given opioids of some sort, when could they resume their MAT after that process safely without bringing in precipitated withdrawals.
Just to make sure I understood you correctly, Edward, if are you saying the patient opts to totally discontinue buprenorphine, and then when can they start?
Correct.
Okay, so if you totally discontinue buprenorphine and before surgery, she comes in for surgery and say she's here for 3 to 4 days, is on full agonist. We do run the risk of precipitating withdrawal. Usually in the hospital, we're using short-acting opioid formulations. It's not really appropriate to use long-acting formulations like a fentanyl patch or a long-acting like oxycodone extended release or morphine extended release when we're managing acute pain. So we're generally talking about using oral and IV formulations that stick around. They give a expected analgesia for oral medications from 4 to 6 hours. So that's like oxycodone, hydrocodone that we're using in the hospital. Those are sticking around for 4 to 6 hours. In general, we can restart buprenorphine after about 12 hours without a short-acting medication. And so what happens is they have to go 12 hours without receiving any of those medications. And so in the perioperative period, the postoperative period, their pain may not allow them to go 12 hours. And so that's the other risk is really it may not be very achievable to go 12 hours without an opioid because of the immediate postoperative pain. But if they can reach that point after a few days, they generally would have to go at least 12 hours when you're using a short-acting formulation.
Because there is some, and this is just something I just thought of, but there is some, what's the word I'm looking for? Some benefits for that pain once they're able to get to the buprenorphine, right? Like it would help with the pain.
Sure.
Okay, yeah. Gotcha. So the second question, you opened up a little bit of a segue for this one, actually. So let's say that this patient, their intention was they discontinued before the surgery with the intention and the plan to resume their MAT or after the surgery, but they come up against a situation where their pain is a lot higher than both parties expected. And they are saying, or they're expressing to you, the provider, that they want to actually continue those opioids and change their plan. How would you suggest, while they still have that pain, how would you suggest that the provider manages that process?
Yeah, I'll draw a little bit on a patient experience without revealing any patient information that's protected. That I faced this situation over the last 2 weeks, and so the patient had discontinued the buprenorphine really without any sort of preparation. Here we're seeing the patient before surgery having a planning conversation, and so that didn't happen for this patient, and the patient discontinued the buprenorphine and did so because of all the sort of the reasons we already said, is that because they thought that stopping the buprenorphine was absolutely necessary in order for other opioids to work, which I've addressed a few of the reasons why there's some misconceptions, both from the patient end and the provider end around that. Now we're kind of on the postoperative period with this patient, and pain is, not extremely well controlled. We are getting there now with a regimen of just full opioid agonists, so something like PO oxycodone. And the patient is really saying, hey, I don't want to go back on Suboxone right now because I have a surgery in a month. And so one thing that I would do is go back to sort of what would be our approach for a patient without opioid use disorder. And so again, for our patient here in this case, again, we weren't expecting opioids to be required longer than 3 days for this patient. And so it really wouldn't be quite appropriate to give them, a 30-day prescription, which is, I had a patient ask me for that this week for a 30-day prescription, and that really just wouldn't be appropriate. And what's happening there is that we're using full agonists, in a way that's really treating the acute pain, but in a way it's also replacing some of the Suboxone, and it's being used in a way that's not intended and not approved. And so that's what I would address with the patient, that I want to provide care that is consistent with how I would care for others, but also be mindful of that for them. And so what I would offer is that we would do a short prescription, as I would with any other patient. I may use higher doses because their opioid tolerance would be higher, but I wouldn't extend the duration necessarily. And that after that ends, that the patient would need to transition back to buprenorphine or run the risk of relapse. Mm-hmm. The other thing that I offer in the hospital, and what we tend to offer and recommend as a consult service, is that we really would recommend going back on buprenorphine as a way to both help your pain, and that there are ways to use buprenorphine for acute and chronic pain. And I'll get into those with the next question. And then also you may need a higher dose temporarily to help with that process, and that it, in addition to helping with your pain, it will hopefully help stabilize any cravings that could occur after this expected duration that we went over before.
Mm-hmm. Yeah, that's, I mean, it seems like also another suggestion that could be made to that patient, if they're saying they're doing it in preparation for another surgery coming up, the provider could maybe mention, or let me know if you agree with this or not, Dr. Bradford, but they could suggest saying, well, if that other surgery is kind of on a similar level of intensity as the first one, then you could say, well, maybe now you know how your body reacts, and maybe you might have a better outcome if you stick with the buprenorphine for the next one, since you've already tried the alternative. The third question, so let me think how to phrase this. Also, Crystal in the chat box, she mentioned, is there a concern of the patient feeling high if taking the post-op opioid, which would lead to relapse? I can give you my perspective, which of course is not that of a medical provider, but just from personal experience. And me even just imagining myself, like right now, if something came up like that, I would certainly be concerned about it. No doubt, because I know how my body reacts to opioids, but I think if I had a doctor or a surgeon or anesthesiologist or nurse or anything like that, that was able to, explain to me that it would be necessary, and that with the doses given, because my body will need it, there's a very low chance of me feeling intoxicated or euphoric or anything like that afterwards. But of course there would be a risk of that. I mean, you don't know, but I mean, Dr. Bradford, did you want to answer that from the perspective of a physician?
Yeah. So thanks, Crystal, for your question. I think that's a concern that we as providers often bring to the table, that we're, by giving opioids, going to sort of induce this high for a patient. Two things to kind of think about that. Number one is that their own, if they're either in active use and using a high amount of opioids, or if they are on a medication that is an agonist therapy, that's buprenorphine or methadone, and they're not on those when they're in the hospital. So if we've taken them off in this setting, or they were using an illicit opioid before and they're not on that, we oftentimes have to remember that they had this opioid, what I call an opioid deficit, meaning that they've been used to a large amount of opioids, and that if that we're giving them opioids at a quantity under that, they're usually not going to feel high. They're actually going to be at risk of withdrawal. And so until you meet that, what I call an opioid deficit, that they're really not going to they're definitely not going to feel euphoria, and they're even more not going to even achieve analgesia. So that's the kind of first principle. The second principle is that there is a difference in different formulations and how quickly they cross the blood-brain barrier. And so if anyone's gone through surgery, may have experienced this as a patient with or without opioid use disorder, that IV opioids work fast, right? They work really fast and they provide instant relief. And all of us, it's human nature when we're in pain to want instant relief. And so that's when I'm working with trainees, I think that we often like withhold IV opioids because of that. And it does reinforce the sort of desire for the IV opioid when someone's in pain. And so what I talk to with patients about is that we're going to use the IV opioids temporarily, but the long-term goal is to get you on an oral opioid that, sure, it's not going to work as fast, but it's going to last longer. And that once we get you to the right dose, you should be feeling your pain better controlled to where you aren't in these moments of crisis where you need instant relief. Our goal is to provide sort of a steady stream that will hopefully be less like a roller coaster and be more of a smooth ride once we get to those oral opioids. And so I do counsel patients in advance that we're going to be using the IV opioids temporarily. For patients without the opioid use disorder, that's because I don't want to sort of put them at risk for that kind of reinforcement. And for patients with opioid use disorder, I also don't want to trigger them in any way. And so really being upfront about that process and setting expectations is something that I think we owe to our patients, and that we need to have an open dialogue with our patients about. And that there is this potential, especially for faster acting formulations, for them to have some reinforcing properties that we may not intend.
Excellent. Yes. The last quick question I had for this case is, and you can answer this from the perspective, I mean, this is just a broad question, but what are some non-narcotic medications that this patient could take post-op to kind of supplement their pain management regimen?
Sure, yeah. So before I add in an opioid, I always recommend at least scheduling something like acetaminophen, so Tylenol. Again, pain is complex, and what I tell patients is that it's going to require not just one thing to treat your pain, and that sure, not Tylenol alone may not be sufficient to treat, someone that's just had a surgery, but that we need to use multimodal pain management to really attack the pain from multiple angles, and that we should be using scheduled Tylenol. So not something, when I'm working with a patient in the hospital, I tell them we're going to be giving you Tylenol. You don't have to ask for it. The oxycodone is there to ask for when you're in pain, but that we're going to be scheduling some of these non-opioid therapies, like Tylenol, like an NSAID, like Toradol or naproxen. We may add on, especially for sort of neuropathic pain, may add something like Cymbalta or duloxetine, which even with patients without depression can be helpful for neuropathic pain.
Excellent. So it looks like Xavier has a question, but I think we will answer that, or Dr. Bradford will, but I think we'll press forward to the next case, just so we make sure we cover everything, but we will get to your question.
Yeah, and I have a follow-up question for here, and we'll go over it briefly. And Xavier, I'll just really quickly just say, I don't, as I said, don't recommend the restriction of IV opioids. I do think it's important to remember that that's a time-limited thing that we're doing, and that we should really set expectations appropriately with our patients to work towards something that's more stabilizing for their pain than just giving the IV opioids. So this is the same patient, case 2 again, and we have chosen for this time to continue the buprenorphine. And remember, I recommended lowering the dose, so we lowered the dose to a total daily dose of 12 milligrams. And I'm asking what you would recommend in this.
One thing I was just going to mention while we're allowing this poll to go through, I meant to mention this earlier, but there's kind of this silence, so I took advantage of it. And I think Xavier's question is one that kind of ties into this, but I certainly, I know it seems like, at least on my end, there's like some anxiety when I go through all this, as far as from my perspective as someone in recovery, or for others. And that's certainly not like I fully understand that there are situations where the pain needs to be managed with opioids. I don't have any sort of grudge against opioids. I just think there are some blind spots every once in a while, and there are some tricky situations where the more knowledge, the better, essentially.
And a lot of times we kind of, as providers, bring in this fear about euphoria, and is it a patient seeking euphoria or seeking pain relief? And sometimes it's not so black and white. And I would just caution against sort of that dichotomous view of things, that it's usually more complex for a patient with opioid use disorder, and that yes, a patient may be seeking pain relief, but there are some times where there are some cravings going on at the same exact time, and that really thinking about how can we target both of those things at once, rather than trying to sort of distinguish which of it is as providers. And sometimes patients may not be able to separate those things as well. And so I think it's just important to recognize that it's quite complex, and that we don't have to separate things into these two distinct things, that it's actually usually both of them acting together. All right, so we'll close the poll and see. This just gets into a little more nuance to the role of buprenorphine in pain management and how it works. So for buprenorphine, when we're using it strictly for opioid use disorder, you'll most often see it prescribed daily or twice a day. It can really be prescribed daily with great efficacy. It's been studied in even in every other day dosing. Buprenorphine is very long acting in terms of craving control and helping decrease the amount of illicit opioid use. Again, that can be done very well with once daily dosing. For patients with acute and chronic pain, the properties of buprenorphines on providing pain relief is shorter acting. So it's usually in the 6 to 8 hour range. So it's not really contributing to pain relief for the entirety of the day if we just give it one time. And so when someone's going through post-operative pain and we've chosen to continue their buprenorphine, what I most often do is what we would do in B or D. The choices here is to divide up the dose. So to divide the dose up into 3 or 4 times a day dosing. Again, the medicine provides pain relief for 6 to 8 hours. So again, 3 to 4 times a day is going to provide greater and more consistent pain relief than giving it once a day. So that's the first step I would take if we chose to continue buprenorphine. And then we get into the other question that's also asked here is, what full agonist should we use? So I've listed here oxycodone and hydromorphone. And it is important to recognize that not all full agonists are created equally, that each of those has a different binding affinity to the opioid receptor. And so what I always tell trainees and patients is that buprenorphine is really jealous, and it's going to try to block out everything. And so we want to, after we've lowered the dose, freed up some of the receptors, we want to give the full agonist that we choose the best fighting chance. And so we want to pick one that has a higher binding affinity. And so the one that has a higher binding affinity of the choices listed here is actually hydromorphone. And I've listed as oral hydromorphone, and for the reasons I kind of described previously, is that we are picking an oral agent here to provide a longer duration of relief than an IV formulation. That temporary use of IV formulations may be appropriate, but really to provide longer lasting relief, that oral opioids is what we want to select. And that here we would choose hydromorphone over oxycodone because of its higher binding affinity. This doesn't really come to play if you totally discontinue buprenorphine, because you don't really have to think about this competition. The oxycodone and the hydromorphone are going to be not having to compete with buprenorphine. But when buprenorphine is present, you do want to use opioids with a higher affinity to the receptor. And so morphine and hydromorphone have higher affinities than something like oxycodone We use a lot of oxycodone for postoperative pain, but it really, for someone on buprenorphine, it's not going to be quite as effective as hydromorphone. Before we move on, this slide is a little more nuanced and would definitely need the help of some trained providers, but I did just want to go over some basic principles. Any questions around dividing the dose or the selection of a full agonist? Okay, we'll move on to the next case. And so the last case is really thinking about harm reductions for patients that are still in active use. And this is a 26-year-old man with severe opioid use disorder, specifically IV heroin and fentanyl, and also coexisting methamphetamine use disorder. He's hospitalized for an MRSA abscess in the left forearm. His past medical history includes untreated hepatitis C infection and depression. He's currently not taking medication and he's unhoused currently. And to start off, we'll open it up with another audience poll here. So we are going to open up the abscess and drain it, and it's experiencing extreme pain. And you give appropriately, again, some IV opioids and temporarily relieve the pain. And so at the same time, what would you also start? All right, we'll close the poll, and if someone would just volunteer to share sort of the rationale behind what they picked, if you would like to volunteer for the group, we'd really appreciate it.
I couldn't vote on the poll. And this is just while we wait for other people to chime in, because I'm not a medical provider, but just based off of the information you've shared so far, I would probably choose C. And my reasoning would be because they would have a higher tolerance. And so because the hydromorphone is quicker or shorter acting, then it might make sense to supplement that with the longer, the one like say like an oxycodone, which is what I'm assuming you mean there. That would be my uneducated guess.
Now you've definitely picked up on some of the principles that I think are really core to managing acute pain, especially for patients with opioid use disorder. And so really, again, the first principle is multimodal pain management. And so really thinking about that we need to attack the pain from multiple angles. And then especially for something like an abscess, that there's a high degree of inflammation. And so even though we sometimes minimize the effect that NSAIDs have, they can be very effective. And so that kind of keeping an NSAID around the clock, like a scheduled high dose naproxen, or even the IV Toradol or Ketorolac that I've mentioned here, can be really beneficial, especially for a condition that has a lot of inflammation associated with it. So I would definitely have a scheduled NSAID on board. And then we had a kind of a mix between B and C here. And so again, I just want to highlight that IV opioids, I definitely emphasize that may be needed temporarily, but that we want to start at the same time. If you start an IV opioid, that you really want to think about how can I make this last longer. It's not about restricting IV opioids, it's about controlling pain for a longer period of time. And that in this case, that we would add on a PO opioid like an oxycodone, or you can use a PO hydromorphone, an oral formulation, regardless of those, are going to last a little bit longer than an IV formulation. And so we want to be able to provide consistent pain relief for a longer period of time. And so that's why I see it is sort of the right answer in this situation, and that we want to start those simultaneously. And what I tell people that I'm working with is that we're starting with a dose that we aren't sure it's going to provide the best relief. And so once we've started with, let's say, oxycodone 5, and we learned that they're still needing IV hydromorphone or IV Dilaudid, that we need to increase our dose of oxycodone to see if we can get more effect from the oxycodone. And that ultimately we'll be coming off of the IV hydromorphone as we get on a dose and a frequency that work well for the oxycodone. And so it's really, the IV is there for backup for when we aren't at the right dose yet of the oral formulation. And that we should really be titrating or going up on the oral formulation to capture someone's pain as we use the IV there for backup as we're doing that titration. And so that's sort of the general principle, is that this first day, we want both of these things present, because we're actively titrating the medications to provide more effective pain control, more longer lasting pain control. And that if that's done well, that we on day 2 can hopefully have the patient's pain managed on an oral regimen that's providing longer lasting relief without the need of an IV opioid.
Did you want me to go into some of the questions I had, or did you want to wait?
Certainly. And I just put the case up there for everyone to review.
So you actually, you pretty much answered my first two just with like the next to last thing you just said, but I am just curious, is it ever beneficial for the provider to, when they first meet the patient or when it's appropriate, to ask them how much street, say heroin, for example, that they're using or whatever they're using without a prescription? Is that ever appropriate?
Yeah, so I work as an addiction consultant, so I'm I come at it from a slightly different angle than, say, like a hospitalist would, because I'm thinking about sort of overall recovery and just sort of what tolerance is. But I think it is a good idea to get gauge what is a patient's tolerance, with the caveat that, when a patient reports that they're using a certain amount of a substance, that we don't really have a way to define that well, in terms of what that really equates to in terms of actual intake, because drug quality can vary quite differently. And so like a heroin fentanyl mixture or a fentanyl only mixture is quite different. But I do think it is helpful to gauge someone's tolerance. And I think it's really important to explain why you're asking those questions when you're talking to a patient, especially in a patient like this that may not be ready to take a step toward recovery yet, that is, if he, quite expresses that that's not his goal, that we should be asking questions that are helpful for his immediate care, and to build rapport with him. And so I think it's really helpful to gauge tolerance, because that would shape what doses you start with for those other opioids that we're using in the hospital.
Mm-hmm. Yeah. These next two questions are more about like the discharge of this patient. Now presumably if you broach the subject of like getting some sort of help for their opioid use disorder or their substance use disorder, and they deny, should you still discharge them with a prescription for naloxone, say, just so they have it? Because it seems like that is less of that's not really prompting that person to get treatment. It's just it's a harm reduction tool. So would you suggest always sending them home or discharging them with that prescription?
Certainly, Edward. Yeah, definitely. Every patient with opioid use disorder, I always ask if they have a Narcan kit, no matter where they are in their recovery journey, like even if they're well into recovery, just because they may be able to help someone else out. And that we also are always sure when relapse may happen. That's a possibility for patients. And to really counsel them about that and to make sure they have access to an naloxone kit for sure.
Excellent. And then presumably you would only, well, this is actually, there might be some layers to this that I haven't considered, but would it be appropriate, let's say that person is at least open to some sort of help with their opioid use disorder. They're not ready to fully commit to anything, but they say, yes, I've been trying, I'm not seeming to have any luck. With the right circumstances, would you consider discharging them with like a short-term opiate, a short-term like a Suboxone prescription, or is that something where you would refer them to a licensed Suboxone physician or a methadone physician or clinic?
Yeah, great question. So kind of thinking about this patient we have before us is first, sort of after we've hopefully managed his pain well, and we've done that by using opioids appropriately. We've also accounted for his opioid tolerance and know that we may need to use actually higher doses to manage his pain than someone that's opioid naive. So rather than starting at like oxycodone 5, that I may need to start at oxycodone 10 or 15. And that's actually expected and appropriate for this patient. And that we shouldn't like lowball someone that he actually has a opioid tolerance and that we need to account accordingly. But once is in a better place to talk about sort of their recovery is really thinking about sort of where they are. If he is open to taking those steps, and I kind of go over, regardless of where people are, kind of recommend that someone be on a medication for opioid disorder. We have 3 approved by the FDA: methadone, buprenorphine, and naltrexone. Those 3 medications reduce mortality compared to not being on a medication for someone with active opioid use disorder. So I always recommend being on a medication for opioid use disorder. A patient, can take that recommendation or leave it. If they would like to further explore, I go into the details of what is required to get on one of those medications and connect them to treatment. I'm an addiction doctor, so I that's what I do here is I help people get started on medications when appropriate. If you aren't in that situation, there are a few things you can do. You can get your X waiver. If you are a doctor with your DA, you can sign up for that today and get it within the next month or so. No cost in addition to your regular DA. And you don't need additional training right now to get that. You just need to go on the DA website and get your X waiver, and you can prescribe buprenorphine and refer to treatment. So those are some steps that I would take. And then for this patient, I would also ensure they have an Narcan kit, and then also make sure that I'm addressing some other aspects of harm reduction. Like this patient came in with an abscess, and that's talk about that may be from the injection use, and talk about safer techniques around injection use.
Mm-hmm. So these next few questions are, I guess you could describe them as especially near and dear to my heart, but so what how should I phrase this? Should the first one is, should the provider ever approach the patient about receiving treatment for their, in this case, receiving treatment for their opioid use disorder while the patient is still under their care? Is that something that you should wait? Like if they haven't said anything about it, but I mean, they have said they use, is that something that the provider should address or ask them if they're interested in help?
Yeah, I think regardless of their interest in help or not, it's our obligation to, we wouldn't wait for a patient to declare that they have like fulminant diabetes before we like screen them. Are we actually like they're, we would go ahead and approach that. So I'd approach it just like any other health condition, rather than like tiptoe around it. I think that patients, while not always, they don't always appreciate this. I think they they want to be treated with respect and dignity and want to have a conversation. And if they don't want to, they will certainly let you know. But I think it's our obligation to ensure that they know that help is available, and not tiptoe around the subject. We wouldn't do that with any other health condition. So I don't really think it would be really inappropriate not to do it.
Mhm. What are some steps that you would suggest some providers take to be prepared on their end to have that conversation with any patient that they might come across during a given day in their practice?
Yeah, so I think it starts with screening, and it's recommended by the United States Preventive Services Task Force that we screen everyone in primary care for both unhealthy alcohol use and illicit substance use. And so those things are recommended that we do that for every single patient. And so number one, screen patients, and they're validated screening tools that providers can look up that are not complicated, are very short, that we can at least screen patients. I think anytime we're screening a patient or wanting to connect patients to help, it's really knowing how to do that. And that's really where it comes with partnering with community providers and resources and social workers to be able to do that. And, busy hospitalists or busy primary care providers may not know all the resources, but it should at least know sort of how you can refer, and at least know like a colleague that you can say, hey, my social work colleague can help with that process. And if that's not in place, that we really should be working in the healthcare system to make sure that's happening. That happens here at UAB, but other hospitals may not have that luxury, but there's social workers and case managers at every hospital, and it really should be a part of the services we offer.
Yeah, that was one of the, I don't know if you would call it a question or a suggestion, but it was maybe, suggesting to providers that they, even though they're very busy, maybe somewhat regular correspondence with hospital social workers regarding those options. So they have that in their mind, where if the patient is like, you know what, I'm done, I want to get help with this, then they can mention those and then just call in that social worker to come and speak with them. So yeah, that's a good point.
And for opioid use disorder, if we're thinking about medications for opioid use disorder, their findtreatment.gov is a national website that helps find treatment services, and you can even filter by insurance or no insurance or type of insurance, and you can also filter by type of medication for opioid use disorder. And so that's a very easy resource for a social worker in a community hospital to implement and to at least provide that information to a patient. And so, there are some low-hanging fruits here that I think we can capitalize on.
Those were all my questions. You said it was findtreatment.gov?
Yes.
Okay, I was going to put that in the chat box.
The last thing I'll close with in this case is that when you're treating a patient, and let's say we've had this conversation about medications for opioid use disorder, and this patient is saying, I'm not really ready yet. I hear you. I'll take an Narcan kit, but I'm not really ready to, stop using it right now. That may be an okay place that you've kept them. Given them an Narcan kit. I think the one thing I would address in that situation is if they're still in acute pain, and you would give someone that doesn't have opioid use disorder an opioid prescription in that situation, that it's still appropriate to give them an opioid prescription of a time limited duration, 3 days, if you would do that for another patient. I think one thing that we're sometimes guilty of is that we want to restrict opioids, but if someone is in acute pain from a condition that you would otherwise treat with opioids, that I think it's perfectly reasonable to give a short prescription, and recognize and know that the patient's still at risk for opioid overdose, and that's going to happen with or without that opioid prescription. But it's really not appropriate to treat the patient differently because of where they are in the recovery. That it's still appropriate at times to give a responsible opioid prescription if you would do so for a patient without opioid use disorder. And so I always just kind of check myself and say, what would I do for this patient if they didn't have a history of opioid use disorder, and just kind of weigh that in my mind before I kind of come out with the course. Great. So I'll close with just a few summary points. So I just want to emphasize that we went over just a few aspects about harm reduction, and that it really can be integrated into every encounter with the patient, that it's not only about healthcare at an individual level, that it's a public health responsibility that we have. That please ensure your patients have naloxone kits. That also includes patients that have family members with opioid use disorder. It includes patients with stimulant use disorder. So really thinking how you can get this in the hands of patients. You can prescribe it if the patient has insurance. Out-of-pocket costs for Narcan is actually quite high. So I really do recommend you thinking about resources where patients can get low cost or free Narcan. I showed you the one from Jefferson County. You can Google Jefferson County Department of Health Narcan, and it will again get you to that free training that people can get, and then also get a free Narcan kit after completing the training. And lastly, please prevent relapse by treating a pain appropriately and creating an open dialogue around using full agonist and prescribing responsibly. And so that doesn't mean not prescribing at all, but it means creating this dialogue, partnering with your patient, and really thinking about how can we prevent relapse and how can we reduce harm. Thank you, Edward, for having me. And this is my email if anyone has questions. And we have a few minutes, just a few minutes for questions before we break off. Thank you all for your engagement and for all the great questions that everyone asked. I really appreciate it.
Thank you, Dr. Bradford. Thank you. That was excellent. Appreciate it. All right, everyone. So we will break for lunch. We will come back at 1:30 Central for our final presenter, which is going to be Dr. Gooden. So looking forward to that, and we'll see y'all in just a little while. All right, welcome back, everyone. Our final presenter today is going to be Dr. Burrell Gooden. As a reminder, at the end of his presentation, I'll have some closing remarks, and then I will put in the survey that you will need to complete in order to get your CE, your certificate. So I will go ahead and turn the floor over to Dr. Gooden.
Thank you, Edward. I think I'm having the same issue that Leah was having earlier with not being able to share. So the host disabled.
Yeah,
you can hook me up there. We'll fire it up.
Let's see. All right, should be good now.
Oh yeah.
There we go.
About that. Looking good? Okay. All right, folks. So welcome back. Appreciate y'all hanging in there. I want to talk to you a little bit here this afternoon about non-pharmacologic pain management, which there are a lot of different modalities out there, ranging from, things like pain psychology to physical therapy and different exercise-based techniques, acupuncture, massage, a whole lot of what are generally referred to as kind of complementary or alternative therapies. But what I'm specifically going to speak with you all today or this afternoon about is really the emphasis on pain psychology, which is a constellation of therapies that are derived from a framework related to how people think, behave, and feel, and how different techniques can be harnessed to help a person better kind of control or manage pain, perhaps without the use of medications like opioids, or perhaps with a decreased need for those types of medications. Excuse me. So move along here then. Find the right button to hit. All right, so here's just sort of the customary slide saying that I have no financial disclosures or conflicts of interest. And that basically means that I take no money other than my salary. And because of that, the thought being is that this talk will be free of bias. The only bias, I guess, perhaps is my thoughts and opinions. Okay, so some learning objectives are just to really address the psychological aspects of pain and adjustments to pain. And some of the psychological aspects are going to require here in a minute for me to just talk a little bit about neuroscience, because if you think about it, really our psychology or our mental state of being is a manifestation of our central nervous system, our brain particularly. So I'll try to keep the neuroscience discussion relatively easygoing, but it is kind of important to highlight some of the points I want to make related to psychological aspects therein. Talk a little bit about different psychological approaches to pain management, and then just present some of the science really sort of showing the efficacy of these psychological treatments and why they may benefit certain individuals who are experiencing chronic pain. So about me, actually just minimize my little thumbnail here so I can see what I'm doing. So about me, my training is a little bit different than Drs. Bradford and Dr. Leish that you heard from earlier, insofar as that I'm trained as a clinical psychologist. When I was getting my training, it was really the track was considered health, but with all the pain emphasis that has gone on in my training, I sort of market myself as just that, a pain psychologist. I'm an associate professor in psychology at the University of Alabama, Birmingham, and I co-direct our Center for Addiction and Pain Prevention and Intervention. And I got my doctoral degree a while ago now, maybe about 12 years ago, at the University of Maryland in Baltimore, and did an APA accredited clinical internship up at the West Haven VA in Connecticut. And I'm currently licensed to practice clinical psychology in the state of Alabama. All right. So here's something important. Recently, the International Association for the Study of Pain completed a revision to their definition of what pain is. And really, when people sort of think, all right, what is pain? How do I describe it? If you do a Google search, what really pops up is this IASB definition, because the International Association for the Study of Pain is thought to be really sort of the foremost sort of scientific body addressing this topic. So what I want to point out to the audience is really some of the stuff there on the right, those boxes on the right that are highlighted in yellow. When you look at the top part, the 2020 revised definition, pain is thought to be an unpleasant sensory and emotional experience. So the important piece there is that when you consider pain, you have to think about the sensory aspect. There will be some neuroscience, but also the emotional aspect, which is the psychological sort of representation of that neuroscience, right? So it's sensory and emotional, right? And it's associated with, or resembling that associated with, actual or potential tissue damage. And maybe that gets a little sort of convoluted and you're like, well, wait a minute, what does that mean? So I think what this definition is really saying is that in a lot of instances, there's tissue damage that might relate to the sensory and emotional experience of pain, but not always. So you might actually have a sensory and emotional sort of representation of pain, what you were describing or what you were feeling, but it's actually not related to tissue damage. That's a key piece, and we'll talk a little bit more about that. That bottom box, right, is talking a little bit more about like, hey, these are some key notes or things to keep in mind, right? And interestingly enough, I never shared these slides with Drs. Bradford or Drs. Leish, but you'll see some common themes that I think are important, and it's sort of refreshing to me to see that we're all sort of thinking about this similarly. So, pain is a person's report of an experience as pain. It should be respected, right? That person's experience is important, right? And in acute instances, pain can serve an adaptive role, right? That's how you know you should remove your hand from that hot stove, right? That's helpful so you don't continue to get burnt, right? But when it becomes chronic, there are many sort of adverse effects on function and psychological well-being that can manifest. Chronic pain becomes sort of a disease process into its own right. To through sort of their life experiences, people can learn the concept of pain. So pain's very subjective, and what my pain is may not be the next person's pain. And what that piece is saying there down on the bottom left is that our life experiences can influence how we come to sort of appreciate pain as a threat to be avoided at all costs, and it's very scary for us, or perhaps as a challenge to be overcome. So while it's scary, we appreciate our ability to try to meet that challenge and overcome it. So I won't necessarily go through the rest of them, but those are some important pieces here. Recognize that the slides can be shared, but also too, at any point when I have something like this, there's usually a citation that goes with it. So if you look at the bottom left, at any point, if you're following along here at home or in your office or whatever, and you kind of just do a Google search of the revised ISP definition of pain, this article and this little infographic here will pop right up. Okay, so a little bit of neuroscience, because again, this is important, okay? So on this slide, what we're seeing is, so if you look on, like, say, the left, if there's a person's finger that's being held over a flame, that finger has specialized neuronal cells in it called nociceptors, right? That basically take that stimulus, that heat, that flame, and turn it into an electrical impulse that will eventually make its way to the brain for you to perceive it. So nociception is basically like the sensation of like, ow, something's wrong there. And what happens then is that there's a cell body that would take that sensation from your finger all the way up your arm to your spinal cord, right? Where it synapses there. And then you can see the little arrow, that orange arrow that's going up. That would be if it's going up your spinal cord to try to get to your brain, okay? On the right is another sort of example of this process, but just showing that when you have tissue injury, for example, like touching your finger to a flame, there's a whole bunch of things that are going on there in the skin, right? Different sort of inflammatory markers or oxidative stress products in the immune system, different, neurotransmitters that will help to sort of enhance or minimize that neuronal signal that's going to go to your spinal cord, okay? So the nociceptor is the basic unit of the pain system. Now, when that signal reaches the spinal cord, right? The spinal cord is what basically connects your peripheral nervous system, that's the PNS, to the central nervous system, which again is your spinal cord, but particularly then your brain, where nociception or this pain signal is going to be perceived. Okay, so the dorsal root ganglion, the DRG, is that primary afferent, right? So it gets stimulated, the nociceptor. And you can see that what happens then at the dorsal horn of the spinal cord, the signal will move over to the other side of the spinal cord and just ascend to the brain. And there are different sort of excitatory and inhibitory pathways that can be activated there. So this pain signal or this nociception can be modified all the way as it ascends to your brain. All right, and this is just another schematic, right? So putting it all together, you can see there's a 1, a 2, and a 3, all right? So the 1 represents, for example, if that nociceptor is stimulated because you touched a flame or whacked your finger with a hammer, right? And that volley of nerve impulse synapses there at number 2. That's where ultimately it enters into the central nervous system, the spinal cord, and it can ascend to the brain one of 2 tracks, right? On the blue track, right? That's a little bit more of a direct connection. It's called the spinal thalamic pathway. All right. The red tract is a little bit more indirect. That's the medial spinal reticular thalamic pathway. Okay. But that nociception signal goes up and they both converge there at number 3, which you can see is the thalamus. The thalamus is the gateway to the brain, right? And from that thalamus, what's going to happen is that the nociception signal is going to go to different areas of the brain, right? And we'll get into that a little bit more in depth, but then ultimately, that's where this sensation, nociception, can be processed and perceived as pain. this is something that people don't necessarily realize, because you might think that that process is just straightforward, all right? Like I whacked my finger, all right, Burl, I get it. It comes into this DRG thing and goes to my spinal cord and then to this thalamus thing that you're talking about and to my brain, and then it's perceived and that's the end of it. But that's actually not the case. There's also a loop. So once it hits the brain, there's a descending pain pathway that goes back down to the spinal cord. So what this infographic shows is on the left, kind of what I was just talking about, right? So that red pathway, that blue pathway is how nociception, the sensation, ascends the spinal cord to the brain. But on the right, the descending pathway shows that the loop communicating back down to the spinal cord, right, goes through a couple of important brain areas like the amygdala, right? And if you know anything about the brain, the amygdala is a fear center. So interesting. So aspects of the brain that are related to fear feed back down to the spinal cord to kind of create this descending pathway, right? But what can happen with this descending pathway is that it's thought that the brain can kind of dampen that nociception signal or open it up, depending upon how it needs to modulate it to sort of get your attention and let it be processed. There's an idea that this whole loop back down to the spinal cord creates what's called the gate control mechanism. And this is the gate control theory of pain, right? So again, this is very neuroscience-y and I get that, but ultimately what this is saying is that once that nociceptive signal reaches the brain and is processed, the brain can then say as a function of maybe fear, right, can open the gate, right? And there's more of a pain signal if indeed you need to pay attention to something that's causing you harm or about to do more of that, right? We know that we have these endogenous opioids, not necessarily the kind that we take as a pill form, but endogenously called like endorphins. So perhaps if you are threatened by something that's about to hurt you, your brain can send that signal back down to the spinal cord in the form of like, say, a natural painkiller, an endorphin, and close that gate, which can help sort of turn the signal down a little bit. So this gate control theory of pain is important. But herein lies the issue with the pain problem, right? In terms of like why this person's pain is not that person's. What hurts me a little bit may hurt Edward a lot, but may not hurt Dr. Leish at all, right? Is that it's a very subjective experience. So let me show you something here. All right, on the left, what we are looking at is an MRI scan of two individuals with their low back. So this is if you were looking at them from the side in, right? And figure 1 corresponds to a patient, and figure 2 corresponds to a patient. All right. Now, what you see on the left, right, and you can see the different little terms there kind of pointing out some of the anatomy, is a very nice looking spinal canal with nerve roots in it that aren't necessarily bouncing off of any vertebra or anything like that. Looks really nice. It says normal discs, right? They're nice and spongy and they got nice fluid in there, okay? And then on the right, you see something very similar, except where you get down to where the lumbar spine meets the sacral spine, and you see those white arrows pointing at a disc that is herniated. And you see a chunk of that disc that's out into the spinal canal, and it looks to be like it's poking on some of those nerve roots, okay? So the question becomes, of these two patients, which one is experiencing chronic low back pain? And I don't have the cool polls that Dr. Bradford had, so I'm just going to let that sit there for a second. Y'all can think about it, right? Maybe something's popping up in the chat, what have you. Take a look. All right. Oh, okay, there we go. So somebody's saying, I think it's that person on the right, okay? And that would make sense because you're looking at this scan and you're seeing something that you think, oh, that's the reason for the chronic low back pain, the person on the right. And indeed, the person on the right has chronic low back pain. But here's the rub. So too does the person on the left. both of these individuals came to clinic and got these scans because they're both complaining of chronic low back pain. Okay. So that's the challenge. And this is something where I will gently suggest otherwise to a point made by Dr. Leish earlier that, the idea of pain is a symptom that something is wrong. And that can be the case sometimes, right? So for example, you might see that in that right picture there, right? Where and especially if this person just herniated that disc, and this is like an acute low back pain situation, you might say, look, that pain is a symptom of that herniated disc, right? So that herniated disc is wrong, we need to fix it, okay? However, in the context of like say chronic low back pain or chronic pain in general, the chronic pain starts to take on a disease sort of process in and of itself, right? Where there may be like the nervous system is now sort of changed. There's things going on in the brain that sort of keep the chronic pain going, right? But there actually isn't any sort of identifiable, there's something wrong to hang your hat on per se, right? Something else that's a little bit sort of alarming perhaps is that what ends up happening in the vast majority of chronic low back pain, and I use chronic low back pain because it's like the most prevalent chronic pain condition, is the majority of people with chronic low back pain look like the person on the left, not the person on the right, right? So that's kind of concerning. And to the tune of about 85% of people with chronic low back pain look like the person on the left. Only about 15% have an identifiable disc bulge or something like that, like the person on the right. That's what the most recent like literature suggests. The other thing is that there are people who look like the person on the right, but yet they're pain-free. So we don't necessarily see them in clinic because they don't have like chronic pain that brings them in, right? But there is a lot of sort of things that don't look right on imaging, right? That might make you think a person has pain, but they don't. So it's not clear to what extent, just because you have like a herniated disc or a disc bulge, that you absolutely will have chronic pain because of it. So the point being here is that while chronic pain is like a disease process unto itself, right? It's not necessarily always a symptom, meaning, oh, if I fix whatever's causing my pain, so to speak, then my pain goes away. It's not necessarily that simple, right? What ends up happening is that in the instance of like, say, the person on the left, they may believe that, no, what's really happening is that I do have a herniated disc, you just haven't seen it yet. So maybe if you just go in there and do a surgery and find it and fix it, we'll be good, right? But then they have a surgery. Or maybe they have another surgery because like, oh, I don't think the first one was good, right? And you end up with a situation like failed back surgery syndrome, which is a thing, right? So there's part of the challenge. Here's another piece, right? Move over to the right, those two pictures there, and we have the story of the two construction workers, okay? If you look at the top, what you can see is a nail through a boot. And that was an individual who was coming down from a job, from a work site, coming down off the scaffolding. And the scaffolding ended up being about like 3 foot above the ground. So he jumps off. And as he jumps, he doesn't notice that there happens to be like a nail sticking up between two boards. And he jumps down right on top of it, right? And even though those are steel-toed boots, it comes up right behind the steel cap and goes, right through the boot. And instantly this person drops and he's in agonizing pain, right? A couple of coworkers scoop him up, take him into the ER, right? And what needs to happen is that nail needs to come out so they can remove the boot and appreciate the extent of the damage and then treat. Anytime they go to touch that nail, this construction worker is just in agonizing pain, just can't be done, can't be removed. What ends up happening is they give them a dose of Ativan, which is an anxiolytic, a benzodiazepine, and a dose of morphine so that they could finally take that nail out of the boot. They remove the boot, and wouldn't you know it, the nail had actually gone right in between the big toe and the toe next to it. It never actually penetrated the skin. think on that for a second. On the bottom is a construction worker who was up on top of a house, putting on a new roof, had his nail gun going, right? And then it jams, or he thinks it jams, but maybe he's out of nails. Either way, he's trying to inspect what's going on so he can get back to work. And, you know, perhaps ill-advisedly, like flips it over to look. All right, but now it's nailing again. He doesn't even think nothing about it. 3 days later, continues to have just this low-grade headache, nothing major, but it's like, maybe I should just go get it checked out. Goes in, explains sort of what happened. You know, the doctor's like, did anything happen? What happened? He goes, you know, a couple days ago, my nail gun wasn't working, and I happened to like look down, I was trying to get it figured out, and I thought it misfired, but I don't know, maybe not. So they end up taking this x-ray, and there you go. This guy's got a nail that went right up through his nose and is like dangerously close to his eyeball and optic nerve or whatever, but didn't really perceive much pain, right? So what this just goes to show is the wide variability in people's experiences of pain, right? As a function of actual tissue damage or the perceived like perception of, you know, what could have been tissue damage, right? And the question is like, were any of these experiences less real? No, they were very real in the eyes of the person who experienced them, right? So this just goes to show the challenge of a person's pain experience and being able to appreciate it, right? Because even though nociception or all that neuroscience I was showing you is pretty comparable across individuals, once that signal reaches the brain and a person is left to sort of perceive it as painful, there's a lot of wide variability there. Just to make it even a little bit more challenging, sorry, I had to open up the chat. Just to make it a little bit more challenging, right? I'll come back to that. How do we assess pain? It's like, all right, just tell us what your pain is from 0 to 10, right? And there's a lot of variability in that, because what's a 5 for somebody is a 9 for the next person, but a 1 for the person who comes after. So even though there appears to be a lot of complexities with this idea of the nervous system kind of generating a pain signal that's ultimately perceived by your brain, we're left with some very sort of rudimentary ways of trying to appreciate the extent of that pain by using these sort of scales here. So what exactly is happening in the brain that might make the experience of pain so widely different across individuals, right? Well, it's important to know that pain, the perception, is 100% in the brain, right? All that nociception that I was telling you about is just a way for an electric signal to get from the site of an injury, right? Or something that's similar to an injury, like your low back issues, whatever that may be, to the brain so it can be perceived, right? So again, pain is a sensory and emotional experience. When you look at this little figure here, what it sort of shows is that, okay, that nociceptive signal goes to the thalamus. And from there, it has to go to different parts of the brain in order to be perceived. The red, which is the only part in the brain where it's just pain, is right smack dab in the middle, and that's the thalamus. But once it goes out to the brain, every single piece of the brain that would perceive pain also is just very, very much involved in the processing of emotions. For this reason, sensation and emotion is the pain experience. They're not really separable. So that idea of like, say, a physical pain versus an emotional pain, in my mind, and in a lot of neuroscientists' mind, is false. It's a false dichotomy. It's not a distinction. You can't separate physical pain from emotional pain. What ends up happening is that when people try to do that, it creates a potentially stigmatizing experience, because physical pain is real pain, but emotional pain is all in your head, right? So that's where we just got to be careful in recognizing that physical pain, emotional pain is one and the same, because to our brain, it's only perceiving pain. It makes no distinction between physical and emotional. Now, the somatosensory cortex may be more responsible for letting you know sort of where the pain is, and does it feel more like burning versus aching, right? But, you know, when the like the anterior cingulate cortex gets involved, that's also related to like, man, this pain is bad. And like, I'm really scared that like it's going to like limit me, or I'm not going to be able to go to work tomorrow, so forth and so on. So that's where the emotional piece comes in. But all that representation together is pain perception and a person's experience of pain. For this reason, nociception and pain are not the same thing, right? Again, nociception is just the sort of electrical volley that your nervous system creates in order to take something like a painful stimulus and send it to your brain so that it can be perceived, right? Because it's not that straightforward, you know, researchers, philosophers, people who do this type of work have come up with something like, say, the biopsychosocial model of pain, because there are many factors that can contribute to a person's experience of pain, right? As well as how they respond to pain treatments for better or worse, right? So there are indeed biological factors like, you know, nociception, okay? Inflammation that goes along with it, how your brain is functioning, right? Disease severity, right? Things related to, you know, if it's a musculoskeletal pain and it's related to arthritis, the extent of arthritis, you know, may be a factor in determining the amount of pain you experience, right? But there are also psychological factors. And it's why somebody who is at risk for developing chronic pain, right, may experience worse chronic pain outcomes if they're already depressed, right? Because a depressed brain is going to experience pain differently than a non-depressed brain, right? Things related to stress and the neurobiology therein can really make pain a lot worse. Or if you're, you know, more adept at handling stress, can also make pain less severe, right? And then social factors. Social factors are very important, right? You know, the extent to which you have social support or people around you that can help you, support you, or not, can make things better or worse, right? And all these things work in tandem. So quickly, when you think about it like this, the idea of pain and a person's lived experience with something like chronic pain can become way more hard to sort of tease apart. Pain catastrophizing. I often hit on this one as sort of a psychological and cognitive just related to how we think about things, right? Psychological and cognitive process. There's been a lot of research on pain catastrophizing, and it's really known to be sort of one of the most potent predictors of pain outcomes, but often in the negative way, right? So pain catastrophizing relates to exaggerated and negative cognitions about actual or anticipated experiences of pain, such that the whole experience becomes magnified, right? I keep thinking about how much it hurts and it's just consuming me. I'm ruminative about it, right? I want it to go away. Well, what is it? What is it? This is the if then, right? Well, if this pain continues, what's going to happen then? And I'm ruminating about it. And then ultimately I feel helpless, like I can't do anything to actually help or reduce my pain, right? And this little cartoon sort of shows, you know, here's a gentleman with chronic pain, and the little monster behind him represents pain catastrophizing, such that, you know, he's already fast forwarded in his mind that his chronic pain is going to become so debilitating that he's wheelchair bound, you know, perhaps he's no longer able to work, his family no longer wants him because he's no longer a provider, they're kicking him out of the house and he's on the streets, right? That escalates pretty quickly. And then some of that research I was telling you about that dates back now almost 20 years ago really shows that the more a person gets caught up in this sort of negative pain catastrophizing sort of thought process, that it predicts poor pain outcomes. So people who catastrophize about their pain are more likely to transition from acute to chronic low back pain, more likely to have greater post-surgical pain intensity and the duration after the surgery. They have a harder time adjusting to things like a knee amputation and more likely to experience phantom limb pain. And then interestingly, this is where some of the opioid medication response plays in. People who are high pain catastrophizers are actually been shown to have poorer responses to opioid medications, right? They require more opioids post-operatively to get their pain under control. They're more likely to misuse their opioids in operative or non-operative instances when they're high catastrophizers, right? And for those, again, in the surgery context, when they were high pain catastrophizing, there was more persistent use of opioids 2 months after surgery and beyond. So all of this sort of sets the stage, hopefully, for why things like psychological treatments for chronic pain have a role in pain management. And it wasn't too terribly long ago, just a couple decades ago, where things like psychological treatment for chronic pain was considered to be more of that complementary or an alternative approach. But as there's been more implementation and more research substantiating this treatment modality, it's really become part of what we think about when it's like, all right, we need to have sort of a whole sort of toolkit for approaching and helping a person manage their pain. And that might be things like pain medicines. There's likely to be some pain psychology involved, just like there's likely to be some physical therapy and other sort of lifestyle modifications that might help. All right. The thing that's challenging is that oftentimes, at least early on in the whole pain psychology revolution, if you will, is that pain psychology was sort of painted as this complex treatment modality that only folks who have all that training I told you about that I have can roll out. And that's not the case, right? Like how do I say this without insulting an entire profession, right? Like these psychological treatments for pain, it's not rocket science, right? And more, the impetus is to create these sort of treatments or otherwise like distill them down such that, yeah, a pain psychologist can do it, but so too could a trained nurse or a physician or a social worker, counselor, right? Even like a well-trained peer, because peer-to-peer intervention is also an important thing. There's not a lot of individuals with my level of training or like as a pain psychologist in America. There's just not a lot enough to go around. The thing that's kind of silly about the training that I did is that, and like me now, is that I might take on one new student a year who's going to be a pain psychologist. And it takes anywhere from 6 to 8 years to get them out there. That is not meeting the current need. So for pain psychology or just psychology in general to sort of hold on to these treatments like, no, this has to be done by people like us, I don't subscribe to that whatsoever. So ultimately, it's how can we make these treatments, a little bit more user-friendly, a little bit more easy to disseminate out into the real world, and actually kind of make them such that, most any well-trained clinician or provider could roll them out, psychologists or otherwise. So this is kind of where things are going and moving forward. And then importantly, moving them out into the front line as frontline therapy. I mentioned, they were kind of considered to be more like complementary and alternative. Now they're a little bit more mainstream, but the problem had always been too, is that, like in my clinic or when I was seeing patients, I do a little bit more research now, but seeing patients, it was in a pain clinic in the Department of Anesthesiology. So what often happened is that like a patient might, present to their primary care, and then primary care works them up and what have you, and then maybe they get referred to, if it's like back pain or something, rheumatology. And then rheumatology sort of works them up and solicits like orthopedics. And they get some, orthopedic or neurosurgery consults to make sure that everything looks good there. Well, no, all right, now it's really chronic, and it's going to require, some good pain medicine. So now we got to refer them to anesthesiology. And the anesthesiologists work them up. And then finally, they're like, oh, maybe you need to see pain psychology. And that whole process takes 3 years, right? And by that time, it's not uncommon for a patient to feel like they've been put through the ringer. A lot of experiences where perhaps, they haven't necessarily been believed, or, their hopes have been built up like, man, I got what's going to take care of you. Oh, nope, that didn't work. Let me just pass you off to this next person. And they're pissed, or they're disgruntled, or they feel helpless. And then lastly, what happens is somebody says, well, you should see the pain psychologist. And they're like, oh, so you think I'm making this all up, right? So they come to see me, and they might not be so pumped to see me, but I get that. Moving these sorts of treatments into the front line, so perhaps even into primary care, so that psychological-based therapies may be one of the first things that patients are introduced to when they come to the hospital or the clinic with pain, and normalizing this as part of the experience, this is where we're at, right? So what does, this psychological based therapy for chronic pain management look like, right? Humanistic approach to patient care. I think Dr. Leish talked about this, and I'm super excited to sort of see that, because this right here, this isn't just psychology. This is being a provider and trying to take care of people. How do you do that? You approach them as humans, humanistically. It's an exchange, right? So it's person-centered. I always like to say that everybody who's tuned in right now is an expert in patient care and taking care of people, but you are not an expert in a person's lived experience, right? The only way that you're going to be able to appreciate that and develop your own expertise is to actually hear what they have to say, right? You want to listen to them. As Dr. Leish said, sometimes when you see them, it may be when they're sort of at their worst, right? So you don't want to allow that to overly color your appreciation for them. Recognize that they may be in substantial grief, right? And what are they grieving? They're grieving the them that they envision for the future, right? It may be that when they come to see you, right, they're no longer employed, right? Or they're having a hard time taking care of their family, playing with their kids, and they're mourning the loss of like the healthy them, right? And they're struggling to find value and meaning in life. I like to think about that like sort of an existential steward of like, you can still have a valuable life. You just got to figure out what that looks like, okay? That catastrophizing, what I was talking about, catastrophizing is steeped in like tomorrow. Man, well, what if this happens? And then tomorrow, X, Y, and Z happens, right? It's important to say, for all of us, you've heard that old saying, like tomorrow is not promised. And that's true. And there's even more of an impetus to stay focused in the here and now, to be able to emphasize the importance of just controlling what you can control, which is in this moment, right? Pain is a condition of self-management. I often like to describe that, just, Dr. Leish gave a diabetes example. Chronic pain is a lot like that, right? You got to put some skin in the game as a patient to recognize that, it's not up to just the physician or the provider to take your pain away, right? You got to get in there and you got to, stick yourself and check your blood glucose and, give insulin or take your metformin, just like you need to, take your medicines appropriately. You need to engage physical therapy. You need to back off sometimes when you're going too hard, or you need to speed up sometimes when you've been on the couch a little too long. So there's self-management involved there. And don't be afraid to be a patient cheerleader. I just grew up where like nobody really got a trophy for second place, right? You earn what you get, so to speak. And I was always kind of like focusing on that, where a person would come back and be like, all right, we talked about you were going to try to do X, Y, and Z. What did you do? And they're like, I didn't do nothing, right? And I'd be like, if you're not putting any skin in the game, what are you going to get out of it? But my stance is sort of softened a little bit, and I think appropriately so, because even if they're like, I didn't try nothing, they came back to see me, right? And that's important, right? Because they didn't even have to do that. So that second or third or fourth visit to come and see me, even though they didn't necessarily try to achieve any of the goals that we set for the week or the 2 weeks previously, they made an active decision to come and see me, which still means that they're motivated to give it a try. That's awesome. You didn't have to come back and see me, but let's go again. Let's try again. You never know, because I've definitely been with patients where it's like week 1, week 2, week 3, week 4, get to a point where I'm like, I don't think I'm having any positive effect. I'm probably close to just letting this person go because I'm struggling to see any reason to go forward. And all of a sudden the next week they come back and they're like, man, this thing clicked and I tried this and it's like working. My pain feels a little bit better, or like my pain's about the same, but I was able to do a little bit more. That sort of click, when it happens, I can't predict that. It's a weird phenomenon, and perhaps you all know what I'm talking about, but being able to cheerlead them on to come back or give it a try, that's huge, right? Because chronic pain, just like, things like substance use disorders, often become conditions where we have to stick with our patients and see them for, repeated visits. Rapport is the foundation of that effective care, or bedside manner, or therapeutic alliance, whatever you choose to call it. But it is crucial to being able to move forward positively as you try to help the patient. right? And this is just a little study showing that very thing. So this is Liz Lowson and Tor Wager. It's just kind of a cool little experimental study where they use like case vignettes of providers where they tried to match them to actual patients with chronic pain to say, this is a provider that, shares similar sorts of experiences as you do, so forth and so on. But the way that they experimentally manipulated this was that the vignette, the fake provider, was either more similar or less similar and provided sort of trustworthiness or lack thereof to the patient. The ultimate finding was that when patients felt like they could trust the provider more, or that there was more of like a similar sort of collaboration towards moving toward the same outcome, their pain reports were actually reduced just by having a nice rapport. So what goes into building a good rapport? And it's tough, right? Because I would say, so what's likely very different in my practice or in a pain psychology practice relative to say like Dr. Leish or Dr. Bradford is that psychology is such that generally speaking, we get anywhere from 30 minutes to an hour to spend with a patient, right? Where, Dr. Leish or like she said she came from like a primary care background, 10 minutes tops. So you got a lot that you want to try to get in there in that 10 minutes that can often then just lend itself to not fully listening or perhaps like interfering with what a person's telling you and making some assumptions or just jumping to conclusions, and that can undermine rapport, right? When you come up with like a plan that you want to try to roll out to a patient, say, this is what I'm thinking, what do you think? Oftentimes we're like, all right, this is what I believe to be pretty simple. Stop and make it even simpler, right? Explaining things, providing that information, re-explaining it if it's needed, it can be reassuring, right? Doing this while trying to understand a patient's perspective. The best, most evidence-based, guideline concordant treatment plan that you have for your patient is going to get you nowhere if the patient is saying, here's the reasons why I can't do that and I won't, right? So there's no point in really moving forward if you're not going to stop and say, all right, let's collaborate a little bit more and see where we can kind of compromise or give and take and like come up with some creative strategies to get better on the same page, right? And that's appreciating, validating a patient's experience. And I often like to say, giving the patient the benefit of the doubt. What I mean by that is, the healthcare system has bias, right? And that's not to, shame any provider or whatever. But the point being is that, you think about a long day, you've seen dozens of patients or whatever. And the last patient of the day, right, is somebody you've never met before, but they sit down and after having reviewed their history and talked with them a little bit, they instantly remind you of the patient you just seen who was super challenging for you. Is it reasonable to think that like, your brain might just jump to the conclusion that, man, this person's just like that one. This one's going to be challenging as well. And that will affect how you might interact, collaborate, treatment plan, or lack thereof with that participant. So sometimes it's important to say like, reset, never met this individual. Like they have the right to sort of tell me what's going on, right? I want to give them the benefit of the doubt because this person hasn't burned me. Granted, the last one perhaps did, but this person hasn't burned me. Like I need to understand and sort of see what's going on and give them an opportunity to succeed. Managing expectations. We talked about this a little, well, Dr. Leish, I think maybe Dr. Bradford talked about this a little bit, like managing expectations is super important, right? Because what can end up happening is that, how you present a, pain condition, like, this is what your pain will experience, most likely be like after the surgery, or this is how much like, relief you might expect from this medication, right? That can affect placebo, right? But the counterpart to placebo, which folks in the audience may or may not know about, is nocebo, right? So, I get the sense that sometimes this is what I was sort of experiencing with patients. As I told you, it might have been 3 years in the making before they even come and see me. They're already told like, oh, you need to see the pain psychologist. So now they're feeling stigmatized because I perceive that this provider thinks the pain's all in my head, right? And then if you present it like, they're like, well, what does the pain psychologist do? I don't know, something about like coping or like, fixes how you're thinking and then, it should help. Well, that doesn't sound very reassuring, and it may actually reinforce the stigma that they were experiencing, and you could create a nocebo effect. So what can happen is that a person walks through the door and they may be poised to benefit from something like pain psychology, but because, excuse me, they already got it in their head that this is a sham and this treatment's BS and it's not real treatment, it's not going to work for me, then it doesn't. So you can actually have nocebo effects. So managing a patient's expectations, how you present various things to them has important consequences for whether or not it can sort of promote treatment and healing and goodness, or the opposite. Okay, so being mindful of time here. All right, so getting into just some of the different options for these psychological based therapies. The sort of the granddaddy, or the one that sort of really kind of kicked it off, was this idea of cognitive behavioral therapy, which has been around for a long time for the treatment of like mood disorders and things like that. But I would probably say in the early 90s, recognizing that like mood, emotions, and pain, and the sensory aspects of pain go together, the thought was, well, might this be adapted and applied to chronic pain treatments, right? And then since then, it's only continued to grow, and there's a nice research base suggesting that there can be some benefit here. But cognitive behavioral therapy places a lot of emphasis on cognitive processes, right, that can largely dictate how a person's mood, develops or impacts their mood, and then how they behave because of that, right? So the thought being that mood and behaviors are largely determined by beliefs, thoughts, and perspectives, right? So if you are having negative thoughts, like, so for example, pain catastrophizing, right? If you can change how a person thinks or engage them in restructuring how they sort of see things, how they think about it, even if they start to go down a pain catastrophizing rabbit hole, to stop that and bring it back and recognize that, like, I can't control what's happening tomorrow. Right now is what I can control. And, if I distract myself from this pain flare by, calling up my child and having a conversation, that might be helpful, right? Excuse me. So that's the piece, is really trying to intervene cognitively, right? To restructure or change some of those sort of schemas, they're called, like thought patterns, right? So again, emphasizing self-management, because lo and behold, like I'm a psychologist, but I don't actually dictate how people think, right? They have to do that themselves. But generally then there's three basic components. There's always an education component, right? So describing the impact that your thoughts can have on mood and behaviors as it relates to pain, right? And again, that those are all controllable, right? Recognizing that a lot of the restructuring does relate to how we think and then cope accordingly, right? And trying to replace like maladaptive coping strategies with more adaptive ones, right? This kind of relates back to what I said earlier when I think about, people who perhaps have pain and then get introduced to opioids and then perhaps develop an issue with those opioids. A lot of that was steeped in they were just trying to cope with that pain, right? And that coping process went awry somewhere. And it may be the case that coping strategy is no longer viable and it becomes maladaptive. So now we need to like peel that back, right? Or take that away. But if you remove a coping strategy, it leaves a void. So it has to be replaced with a better, more adaptive one. And this is where some of the cognitive behavioral therapy comes into play of, well, what are alternative, more adaptive coping strategies, right? And then, there's a whole myriad of that related to like, pleasurable activities, related to distraction techniques and things of that nature. But a lot of this, gets addressed in that 1 hour session that I might have with the patient once a week or twice a week. But, that's tough to think that, that'll be the end all and be all. Whatever happens in that 1 hour session is enough. So it's really important to try to apply and maintain the lessons learned in a CBT session in the real world, and addressing the barriers that may prevent a person from really uptaking new coping strategies and different ways of thinking about things, and problem solving how to address that when those barriers do present themselves, right? So the CBT piece related to education, a lot of the education that I provide to patients involves things related to gate control theory. So letting it be known that how they think and how they behave can actually reflect in their own sort of neuroscience to open or close that gate, right? The importance between like acute pain, where that is more of a symptom, but chronic pain, it becomes less of a symptom and more of a disease process itself, right? And sort of because of that, you know, it may be more prudent to engage in the self-management rather than trying to find the silver bullet that's going to take this pain away entirely, a surgery or some magic pill, what have you. And then deconditioning and activity rest cycles, right? What happens is that with fear of the pain, people may be less likely to engage in activities which can be beneficial for the pain. And then with that lack of engagement, they decondition. They decondition physically, you know, muscles sort of deteriorate, but also psychologically, there can be a deconditioning or a deterioration that can sink a person even into greater depression and despair, right? So then skills, right? And with cognitive behavioral therapy, an important skill is relaxation training, progressive muscle relaxation, because the thought being is that chronic pain itself can be a toxic stressor, and all that stress then creates a problematic loop that only makes pain worse, and pain gets worse and becomes more stressful and so forth and so on. So learning how to relax is important. And then you can see the different strategies there. You know, and again, something, you know, it's sometimes the case that patients may resonate more with, you know, accessing their social support. And that may be friends or family or the church or whatever it is, right? And they're less likely to engage in coping self-statements because they're like, I don't want to talk to myself. That's silly. I like when other people, you know, kind of engage me, whatever. So that's why, you know, options can be a good thing, right? And then just again, identifying and challenging those maladaptive thoughts, because pain catastrophizing can sort of creep up even when you're not really expecting it to. So identifying it, kind of stopping your thought process, reorienting and going again. All right. So these things get implemented in session, but the key ingredient is that they're practiced outside of session. This is what might be referred to as homework. I don't necessarily like to call it that, but ultimately the practice, this is where I said sometimes, like, you know, a patient may come back and be like, I didn't practice any of this since the last time we met. And all right, I'm not mad at that, but here you are again, and here's another opportunity to try. So what didn't work? And we can problem solve. And the research looking at cognitive behavioral therapy when it's applied to chronic pain outcomes has generally shown that there can be decreased pain intensity and psychological distress, increased physical functioning and role function, you know, so that's just emotional and social functioning, decreased maladaptive thoughts and behaviors, and importantly, an increased use of adaptive ones, and then increased self-efficacy for pain treatment. So that can be important too, why sometimes it takes a toolbox of pain treatment techniques, right? Because it may be that if a person has a nice response to say something like CBT, they feel like they're more ready to engage physical therapy, right? And then perhaps with better outcomes in physical therapy, they're less likely to require their opioid medication or something like that, right? So sometimes these treatments can really synergize to benefit the outcome that we're interested in, which is, you know, chronic pain management. As a scientist, I always appreciate a little bit of data, not to get too overwhelmed by this, but really what this was is a review article of a bunch of studies from the past. And what this really showed is that this is focused on cognitive behavioral therapy for chronic pain. And if you look on the left, those like 3 sets of bars on the left, CBT versus passive controls, right? The outcomes that they assessed were pain intensity, disability, and mood, right? And CBT versus a passive control would just be like a wait list or just care as usual. And what that showed is that in blue, so that's immediately post-treatment after the CBT, you actually did have a nice effect on decreasing pain. And then at follow-up, which was anywhere from 6 to 12 months, you know, what you saw particularly for mood is that mood was still, you know, doing nicely, right? CBT versus active controls, an active control might be more something like an exercise plan or a support group or an educational pamphlet. And interestingly enough, there you see even better effects, right, on pain, disability, and mood for CBT, right? Now, without getting into all the background, you know, why this may look a little wonky is that some of the studies that were included here were like low quality, maybe only included like 10 patients in the CBT group versus 10 patients in like, say, the wait list control. And when you have that small a number in a clinical trial, they can really be biased by any one person's response. So this was kind of a low quality set of studies that were included in this review. So they redid it again a couple years later. Sorry, I'll go back. If you look, that was 2009. Redid it again in 2012. And they were a little bit more stringent on the quality of the studies that were included. But interestingly enough, you see that that actually helped show the more actual effect of CBT. And you can see post-treatment, a lot of people were benefiting in pain and disability and mood. And that mood benefit tend to be pretty durable. So it stayed on, you know, at like 1 year post. And then in active controls, you see a nice impact on disability. So what this really means is that a lot of times it's not uncommon for a person to engage something like CBT and really derive a benefit as it relates to their ability to like function and their mood, right? Even if there's not a profound impact on their pain severity, right? So it may be that, you know, what's considered a clinically relevant pain reduction is if you go down like 2 points or more on that 0 to 10 scale that people are always talking about. So CBT, you may only go down a half a point or a point, but what ends up happening is that you get a nice mood benefit and then a nice like functioning benefit. And it's not uncommon for that mood benefit to precede the functioning. You're feeling better, right? You have a better outlook on things. And then because of that, there's perhaps more of a can-do attitude and you're getting up and you're doing things, recognizing that the pain's still there, right? But you're seeing it maybe more as a challenge to overcome, which allows you to engage in more things, living your life. Okay, cognitive behavioral therapy. And then from that was born like more acceptance-based therapies. And the reason why these came about is because in its essence, cognitive behavioral therapy says, hey, stop thinking about that. And then generally what happens is if you ever tell somebody to stop thinking about that, they think about it more, right? So recognizing then the CBT wasn't necessarily working for some folks because the more they tried to stop thinking or thinking about it differently, they tended to just think about it more in the exact same way, which was a problem. Acceptance-based therapies, which is, you know, sometimes referred to as acceptance and commitment therapy or ACT, is more about not necessarily changing your thoughts, but engaging your thoughts and trying to diffuse that thought from an emotional response. And maybe that sounds a little hocus pocus, right? But recognize that it is possible to be done. That whole premise there is what's called cognitive diffusion. That's the middle sort of row there in the slide, which is just trying to find ways, and this is where you know, a well-trained individual with this type of modality can help you to minimize the meaning and significance of a negative thought, recognizing that it's just the thought, right? So, man, this pain is bad today. Yes, it is, right? Doesn't mean that like it's going to continue to just be that bad for the rest of eternity, or that it doesn't necessarily mean that, you know, something's inherently wrong now and you need to go to the doctor to get it figured out. Just recognizing that it's just a thought, you can have it, let it go, and try to get back to what it was that you were doing. And one of the ways to really help promote cognitive diffusion is psychological flexibility, right? Or fully immersed in the present moment. There's that present moment again, based on what the situation affords, changing or persisting in behavior that is consistent with your chosen values. So if you know anything about these acceptance-based therapies, one of the ways to try to like flex your psychological muscle a little bit more to create more flexibility is mindfulness, right? And mindfulness is a key aspect, and you know, mindfulness meditation is a fairly popular sort of technique. You know, a lot of yoga studios and things like that across America involve, you know, mindfulness meditation, and there's various centers that have popped up. Mindfulness is a core aspect of acceptance-based therapies, but mindfulness is that awareness that emerges with just purposefully attending to a thought or a sensation but trying your best not to judge it, right? And the thought being that when you're mindful like that, you can create more of that cognitive diffusion where just because you have a thought or you notice a sensation, you don't have to react as negatively or as viscerally to it, right? And what the evidence has sort of shown is that in doing that, you can reduce the amount of distress, anxiety, and then behaviorally, you can reduce the amount of avoidance that a person experiences, right? And then because of that, they become less disabled, or more willing to engage and just experience sort of their life for what it is. I often tell folks acceptance doesn't mean giving up, right? It's not meant to be pejorative. It's not meant to be like, well, you should just accept this because there's nothing else that can be done. It's not that, right? It's basically, it's recognizing that for today, because we're in the present moment, this chronic pain is my reality. I need not necessarily let it dictate me, although it is a part of me, right? How can I sort of move past it in order to accomplish some of the stuff that I'd like to do today that's consistent with just my values, right? What are my values, right? So this is a study that was done a few years ago now, well, a few years, showing my age, I guess a little over a decade ago, that sort of pitted this acceptance and commitment therapy versus CBT for chronic pain. And this just sort of shows you how the sessions would break down. So on the right with the CBT, you can see more of like the relaxation training, right? And a little bit more of the cognitive restructuring piece, identifying and challenging negative thoughts. But on the left with acceptance and commitment therapy, you can see a little bit more of like the value identification, the limits of control, right? So just focusing on experience, body scanning, trying to focus on the mindfulness and the cognitive diffusion, and then reviewing, practicing, and implementing that, right? But it just goes to show that, yes, these are psychological therapies, but actually when you take a deeper look, CBT and this ACT, this ACT, actually have different aspects and different goals that they hope to achieve. Now, different therapeutic mechanisms that they hope to engage in an effort to achieve the same goal, which is, decreasing chronic pain. The reason why I think this is important is because psychological therapies, just like any other type of therapy, isn't one size fits all, right? There are some individuals for whom they might consume an opioid and it works and it helps them. And other people might have an opioid and they get really sick and they don't like it and they don't want it, right? Well, there's differences there such that an opioid doesn't always help everybody. So you need something else. Just like in psychological therapies, like something like CBT might not help everybody. What if they're a little bit more amenable to ACT, and maybe that helps them out, right? So in that same study I was just talking about, what we see here on the left is sort of the time course of rolling out an acceptance and commitment therapy versus CBT. Importantly, what it really showed is that they were comparable, right? So they both had similar impact on, decreasing the amount the pain interfered with daily living. They improved depression and anxiety, right? The CBT group found a CBT to be more credible and had higher expectations of positive outcomes. But the acceptance and commitment group reported higher treatment satisfaction at the end of trial. So I think, again, what this just shows is that it's not necessarily that one's better than the other, but there appeared to be a differential preference. Some people thought, oh, the CBT, that's probably a little bit more legitimate. Other people thought, ACT, man, that's something like I really liked, and I could maintain that. So it just speaks to different strokes for different folks. Importantly, though, both can provide meaningful, like positive pain outcomes. All right. And then the last sort of modality that I want to draw your attention to, right? And I guess I'm trying to be mindful of time. I'll be wrapping this up. I always get a little long-winded here. This is an interesting one. This is mindfulness-oriented recovery enhancement, or MORE. And MORE so it was developed by a gentleman named Eric Garland, who is actually a licensed clinical social worker by training. He's out at the University of Utah and runs a center out there that's really focused on mindfulness-based interventions. Excuse me. And MORE is a bit of an amalgam or a coming together of kind of cognitive behavioral therapy and some of the ACT-based principles, right? But the components, again, are that mindfulness training, because again, the mindfulness training is thought to be the sort of way that individuals can, create more cognitive and psychological flexibility, right? to then be able to reappraise thoughts as like, okay, that's a negative one, and I'm going to change it to this, as opposed to just getting consumed by their thinking, right? And then the thing that's interesting here is the savoring aspect. So savoring is meant to be sort of like developing a better appreciation for naturally rewarding sort of experiences, right? Like watching a sunset with a loved one, the sort of subtleties and appreciation of like a bouquet of flowers, really savoring, because savoring engages the same sort of neurocircuitry that Dr. Leish was talking about that can be negatively impacted due to like say opioids or things that like increase dopamine sort of exogenously, not from within. So when you take a medicine, right? So the various components to more, right, try to engage these treatment mechanisms, right? And just that's the green box in the middle, attentional control, right? A shift from affective to sensory processing. So shifting that away from affective means just less of a propensity to sort of freak out or catastrophize about the pain. Meaningful cognitive change, just to be able to appreciate like, this is where I'm at today. How can I move past it? And then again, the savoring piece for sort of restructuring reward process. Okay, so you want to target basically attentional biases of pain and opioid cues so that they become less salient. You want to target pain perception and interference with the goal of decreasing those. You want to increase your emotion regulation so that you don't become what's the word I'm looking for? Consumed or overwhelmingly dictated by your emotions. You can regulate them, not them to have to regulate you. And then sort of automatic reactivity and craving as a way of decreasing that. So generally speaking, more is rolled out in 8 to 10 sessions, and you can sort of see what the various sessions might look like there. I included the link to Dr. Garland's center page if people are interested in that. Recognize that, like I know Eric and I like him, but I'm not involved in any of his research and vice versa. So I have no endorsement here other than to say that I think this is a really cool therapy. And I think that it's kind of the wave of the future coming at you. So, the thing about more is that Eric was very interested in sort of co-localizing or really focusing not only on the pain outcomes, but also issues related to opioid misuse as part of a single therapy, right? So here's one of the first studies that he was able to publish on, showing that the important thing that more therapy did was, not only just sort of dampen down some of the negative things like pain catastrophizing, but it really accentuated the positive psychology. And that's sort of, it seems intuitive, but it's kind of a revelation in psychological treatment, is that it may not be enough to just decrease depression. You got to also increase satisfaction and enjoyment and positive psychological things. They're not necessarily two sides of the same coin, meaning just because you made a person less depressed doesn't mean you necessarily made them happy as well. See what I'm saying? So the little schematic there on the left really shows that what Moore was able to do was increase positive psychological functioning pre to post treatment by increasing positive affect and meaning in life, increase savoring, so that appreciation of naturally rewarding stimuli, as well as self-transcendence, which is a sort of a mind-body phenomenon of like being able to move past just yourself, but appreciating that you're part of a bigger picture and becoming more appreciative of your role in the world and the cosmos and all that stuff. So when he then looked at more relative to just a support group in terms of how it might have affected pain and opioid misuse, this is the schematic on the right, an interesting sort of phenomenon occurred where the solid lines represent sort of significant effects and the dotted lines not so much. But what he saw here was that more relative to a support group significantly increased that positive psychological functioning. And then if you go straight down, that positive, the increase in positive psychological functioning was related to decreased pain severity pre to post treatment. And then as a result, that decreased pain severity was related to decreased opioid misuse risk at 3 months follow-up from the treatment. So now it's sort of showing a pathway by which this psychological-based therapy known as MORE may function and work. This is really cool. And then one more piece of study here, and this was actually just published by Eric's group earlier this year. This is, again, part of the push to bring these treatments from sort of the tertiary care model, like, being stuck in a pain clinic, and it takes all the various referrals to get to that individual, bringing it up into primary care. And this was a study whereby MORE was rolled out relative to a support group. So these are clinical trials, right? A patient gets randomized to either MORE or a supportive group therapy, but in 6 different primary care settings throughout Utah, right? And what they did is they rolled out the treatment and then tested to see its effect on co-occurring opioid misuse and chronic pain, right? So these were patients that were brought in that had a chronic pain condition that were receiving opioids for said pain, but had some sort of history in the last several months of having used the opioid in a way that wasn't necessarily indicated, right? Misuse. But really what it shows here, right? If you look all the way to the right of this little infographic, is the findings were that the MORE intervention significantly reduced both opioid misuse and chronic pain through the 9-month follow-up compared to the supportive group therapy, right? So I mean, I think this is really neat, right? Because what this is showing is that, this particular treatment itself is not only conferring benefit for chronic pain, but also helping individuals to be better stewards or to use their opioids in ways that are less risky, right? I'm always thankful, trying to be thoughtful how I present that so I don't use stigmatizing language, but this is very neat. I think this is important. As I mentioned, Eric is actually a licensed clinical social worker, which speaks to the fact that you don't just have to be a psychologist to do this work. And I know that on the heels of this particular study here I'm showing you, Eric is very thoughtful about how do we disseminate MORE and get it out into the various clinics, primary care or otherwise, so that it can be used to hopefully benefit patients across America and beyond. All right, so wrapping up here to recap, psychological aspects of pain and adjustment, right? So I hope now you can appreciate that there really is no good way to disentangle physical pain from emotional pain. It's just pain, and pain is a manifestation of physical and emotional, right? And the physical actually is more the sensory piece, right? But so because the psychology is so intimately woven into a person's experience of pain, this is why psychological approaches can actually have a benefit when it comes for pain management, right? And the fact is that there's a good body of evidence really speaking to the efficacy of psychological therapies, which I think has helped move them from sort of the fray, as an alternative to really sort of frontline treatment. And people like Eric Garland are continuing to revolutionize these psychological therapies to try to meet the needs of where patients are at right now, right? So the remaining questions of importance, at least in my mind, is can these psychological approaches perform well enough to actually mitigate or altogether eliminate the need for opioid medications? And maybe at least for some people, it may be the case that it could be a standalone therapy and a person gets enough relief that they don't necessarily need the opioids. I'm not anti-opioid, but just saying it may actually help people enough. We need to sort of figure out where that sort of lies in terms of who benefits to that level where they might not necessarily need an opioid, but for some individuals who would still benefit from the therapy, the psychological therapy, and the opioid. What dose of therapy is enough, right? Psychological therapies are notorious for being 8-10 weeks long, which is kind of difficult, right? For people who otherwise have busy schedules, or just for individuals who are suffering from chronic pain and might struggle coming back into a clinic, right? But that also speaks how best to deliver it, right? Can these therapies be delivered, virtually? And there's some emerging evidence to suggest they can. So providing, multiple sessions versus single session options, in person versus virtual, one-on-one versus group-based, for whom and under what circumstances? Those are questions there. And then again, last but not least, is just recognizing that psychological treatment does not work for everyone, right? And how do we identify those who are most likely to benefit? And that doesn't necessarily mean if you're not likely to benefit that you're just left out in the cold. I think it's important to understand, well, why might those individuals, like why can't they benefit? And for those reasons, is there anything there that can be changed such that if we do change those barriers to benefit, would they then subsequently benefit? Hopefully that made sense. But on that note, I'll sort of leave it, stop there. And again, there's my name and my email address, just in case, we do the Q&A and you don't necessarily get an opportunity to have your question answered. By all means, reach out to me. I'd be happy to answer any questions.
So thank you, Dr. Gooden. That was amazing.
Probably a lot, my bad.
No, all three of y'all killed it today. Incredible. So one question for you, Dr. Gooden, that came in during your presentation is from Meredith Guthrie, and she asks, are CBT and ACT potentially able to be implemented in a piecemeal or a smaller, much smaller scale in an inpatient critical care environment with the average patient we see in a population with lower educational levels or health literacy from a nursing standpoint?
I love that. That's an amazing question. Yeah, so it's an amazing question, right? Because it's real, right? And what I mean by that is this is where we need to be. So here's the deal. To Meredith, the answer I think is sort of, right? and because there are ongoing efforts. If anybody out there is familiar with, say, Beth Darnell's work, Beth Darnell is a pain psychologist out at Stanford University who has done a lot of work trying to distill these psychological therapies into a single session, right? So not 8 sessions over, 2 months or whatever, but into a single session that can be rolled out into various like real world settings, not a laboratory, but like an inpatient clinic or something like that, right? That can then be provided to patients who may have like low education or things like that. So I think the answer is yes, right? They can be rolled out, right? Like I said, Beth Darnell has done a lot of that work trying to distill them down into a single session that perhaps could be completed in, say, like 50 minutes. Right. And I understand maybe that's even a little bit longer than what you might like, but also too, got to recognize that, these aren't medicines that kick in after 5 minutes, right? Like there has to be at least enough time dedicated to get through the content and allow a person to have it soak in. Alternatively, there was a CBT treatment referred to as LAMP, which is literacy adjusted, it was basically a CBT treatment that was meant for individuals who have like lower literacy and maybe don't have a lot of like the psychological mindedness, that might be required for some of these higher order sort of treatments that really required like deep thinking. And again, I don't mean that to come off negatively. I'm just losing my own track of thought. But the point being is that, that this was rolled out in a PCORI-funded study by Beverly Thorne at the University of Alabama in Tuscaloosa. And it's readily available because anything that PCORI funds that creates a treatment or whatever has to be given back to PCORI so people can go and find it, right? So, so the point being is that, like, if you just Google search Beth Darnell and you find like her webpage, which is out at Stanford, Snapple was the name of the lab. And again, I don't struggle like what that stands for. But like Beverly Thorne's LAMP therapy for pain, which can be found on the PCORI website. LAMP, learning about managing pain. But again, like I said, it's literacy adjusted. So these are sorts of things. This is where things are going, to be able to roll these things out in real time in real world settings that are on like the primary care setting or the inpatient setting or things like that. Man, if I could just keep it short, I would amaze myself. What else?
If there are not, at the end, Edward, if there are not other questions, I'll share a website too that has some free internet resources.
Awesome. I think the only other question that came up was from Crystal asking, how can I bring more to Southwest Virginia? And Crystal, I mentioned while Dr. Gooden was still talking that one suggestion would be to access the link that Dr. Gooden had in his presentation. And if you missed it, and this would be for everyone in attendance, if you missed it, we'll send out our media and events coordinator will send out all of the presentations from today. And you can access it on that. But I mean, Dr. Gooden, did you want to add anything else as to how maybe Crystal could make that happen?
Yeah.
Questions?
So there is an American Association of Pain Psychologists, right? And I'm not sure how comprehensive it is. I was just looking like I'm a pain psychologist, and I'm actually not a member of that, so I'm not represented. Maybe I should be a member of that. But the point being is that if you go to the American Association of Pain Psychologists, I think that's the AAPS, right? The American Association of Pain Psychology, right? It gives you a little bit more information about pain psychology resources, as well as like a little bit of like where pain psychologists are currently at in practicing. So I understand, you know, to like Crystal being in Southwest Virginia, you know, like I'm looking, I can see it looks like, you know, there's some pain psychologists in Richmond. Granted, that's Eastern Virginia, so perhaps not the easiest to get to, but yeah, maybe like, you know, in the Tri-Cities, you know, Kingsport area, whatever, Bristol, Johnson City, there may be some individuals there. But again, that's my point, is that you might be able to search some of these resources and find it. But the other thing is that there's just not enough like actual clinical psychology, pain psychologists, right? Like I'm doing my best to train them, right? But it literally takes 6 years just to get them out the door. Right. And I've been doing this for like 12 years and I've graduated 5. Right. So like that's not enough to meet the demand. It just is not. So the fact of the matter is that, you know, these treatments, these psychological based therapies, excuse me, need to be user friendly enough so that way they can be adapted, you know, they can be used by physicians and social workers and counselors and stuff like that. And frankly, I think they can. Like I said at the beginning, I don't think there's anything so intrinsically psychological that nobody else can get it, so I have to do it, right? That's not it. I definitely think that these things can be done. The challenge, to get back to Meredith's point, is how can they just be done quickly and effectively? And that's where the challenge is, because, you know, nursing practice, physician practice, much more bang, 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 10 minutes here, 5 minutes there is a lot different than traditional psychological practice, which is, you know, spending 45 minutes with the patient. See what I'm saying? So there's some still adaptation that has to happen.
And Dr. Gooden, I love that, Burrell. I love learning about it. I'm one of those physicians that wishes I had your training. I did just, when we talk about reaching remote places, I wanted to share some of the VA websites, if that's possible. You mentioned the PCORI studies, and there's been some at the VA, and anything developed by the VA is then free to the public. I can put the websites, the links in the chat, but if Edward, if you want to give me the option of sharing, I can also just show people a couple things, if you're okay with that.
Yeah. And I realize, like, I use these acronyms all the time. And I remember, like, maybe not everybody is familiar, but like we said PCORI a couple times now, right? So PCORI stands for Patient-Centered Outcomes Research Institute. It's its own thing that is like separate from, say, like the National Institutes of Health, that exists to like fund studies and generate medical knowledge that can improve treatment, so forth and so on. That's PCORI. Sorry, let me go ahead.
I think Dr. Gooden might have to stop sharing his screen.
I can do that. I can do that.
I think. I would assume so, at least.
There you go. How about that?
Great. Let me the screen one. All right, you see my screen?
Yes.
Yeah.
Looks like the website. And so this is the VA Whole Health website. When you first go on it, it looks like this, like what is whole health, and it has a video. I click on veteran resources, which is the same as patient resources in the VA world. There's handouts, there's stories that you can watch. I'm a big fan of mobile apps and online tools. And so then you can see these are, some of them are like CBT based and ACT based mini interventions for a patient to do at home. They always come with a disclaimer that they're done better with a psychologist, but you know, if you don't have one, it's better than nothing, right?
Yeah. I feel
so-
like that statement is like for liability purposes, right? Because again, I just don't know how true it is. Right? Like, but anyways.
I mean, two minds are always better than one, right?
I get that.
But at least if we can start working with one person, if they can do something and gain some knowledge from this stuff. And so there's a bunch of coaches, which are like interactive things where you type stuff in. There's some yoga primers, Tai Chi stuff for pain, biofeedback stuff for pain, meditation, and mindfulness stuff. I mean, it's a really a wealth of resources on that VA website. And then I also often use the PTSD coach one, sometimes for my pain patients too. Specifically, it says I want to work on my worry or anxiety. And then you can do like changing feelings by changing your thoughts and changing negative thinking patterns. And those are very helpful things that do a lot of what Dr. Gooden was kind of mentioning. And so I just wanted to share those real quick because
That's
it's
awesome.
free. It's all free online.
That's awesome.
Yeah, that is awesome.
I'm glad you did that. Should have probably done that myself, but did not. So nice work.
Well, that's from working at the VA a lot.
Yeah, sure.
Awesome. All right. We're coming up on 3.